Hey guys, am I audible, visible? Hello, hi. If I'm audible and visible, just comment yes or no if you guys are live. Hello, Dharmesh. Good morning. So today, I hope you are enjoying the marathon session. I hope you are getting tuned into INICET and one complete notebook for you to revise the day before the exam, the Saturday and Sunday before the exam, right? So today we'll be having pathology, we'll be having pediatrics, and we'll be having surgery, right? Uh, Surgery will be the biggest chunk of today's session, next pathology and next pediatrics. Pediatrics you cannot ignore for the only reason it does not have an overlap. So you have to attend everything, and I hope you guys will be enjoying today's session. I hope you have the digital copy of the workbook also. Just keep scribbling from wherever it is. Fine. Okay, guys. So let's start. So this is the routine. You have the advertisements and the timetable. Now let's go to it. See now what I'm going to try to do with pathology workbook is I'll just give you an overview of what this workbook actually has. Fine. So if you look at INICET in general, this is for anyone who is going to write INICET. You must have definitely known about this. INICET and NEET PG are thoda different, right? So INICET has a little bit of focus on few topics which generally is not covered for a NEET PG prep. Like you will have things about a pathology lab, the fixatives used, the instruments used, right? The instruments, the fixatives, the stains, right? These are not generally covered in case of an NEET PG. They do cover, but it's more of an integrated approach. So we'll be first few like 20-30 minutes, we'll be covering the instruments, the labs, the equipments and everything, right? Then my major focus will be on hemat, because hematology is something which is bread and butter for INICET people. They love hematology. They'll ask questions mostly on neoplasms, the leukemias, lymphomas, and everything, right? We'll definitely focus on RBC, WBC, a little bit more in that, right? Then I'll be going to systemic pathology. Please remember, systemic pathology in INICET is about overlap and it's about vertical integration. You need to have a very strong hold on medicine and surgery in order to attempt it, right? If you are very strong in pathology, glomerulonephritis question, right? If you are very strong in pathology, you can solve with that also. But I would say be vertically integrated, so the number of mistakes will definitely come down, right? We'll also focus on few important things in systemic pathology, just like GI tumors is important, glomerulonephritis is important. There's a big table on postmortem appearance of MI, it's important. These are few things which are very important for us. We'll definitely look into that, right? And when it comes to general pathology, if you look at the last few years of INICET, like 2, 3, 4 batches of INICET, there's not much questions on necrosis, apoptosis, inflammatory mediators, nothing much, right? Genetics, yes, definitely. I'll definitely touch base on genetics because it might be useful for your pediatrics as well. Rest of the general pathology, not much of input. Yes, definitely tumors, tumor markers, we'll definitely look into that for sure, right? So if you're ready to go, we're going to start the session marathon. I want it to be more interactive, not just like lecture, right? So Dharmesh, Inhan, Optimism, Anuj, everyone who's live, I want you guys to answer so that it's a more of a revision session, not just a one-way lecture, right? So let's start. Okay, pap smear. Which sir will definitely talk about pap smear, right? Pap smear, what type of investigation is pap smear? Can anyone tell that? What type of investigation is pap smear? Is it histopathology? Is it cytology? Is it exfoliation cytology? What type of it is, right? Pap smear is a classical example for exfoliative cytology. Fine. So once we touch base on exfoliative cytology का मतलब it's just I'm taking a swab, rubbing the place, not poking it, taking the shed cells. There are multiple examples for exfoliation cytology. This is an important and favorite topic for your INICET people. Zinc smear, which might be covered in dermatology also, in the ulcers, in the oral cavity, in the herpes smear, you keep touch and make it zinc smear, right? Urine cytology, sputum cytology, all of them are shed cells. These also comes under exfoliation cytology, right? These are few examples for exfoliation cytology. Perfect. I'll come to it. Hello, amigo. The questions which is there, okay? Font, you want it to be smaller, bigger? Okay. So now there are multiple instruments used in pap smear. The older one is IS spatula, which is it was in metal previously, kind of sterilized. Now it's in a user and thrower thing. You have one of it, it'll be bigger, one of it will be smaller. It goes into the cervical loop and you have a twist, right? You have a 360-degree rotation that kind of gets the mucus from the cervical lumen and also gets a shed epithelium cells from the cervical lumen, right? Then we have cervical brush and we have cyto brush. cytobrush, cervical broom. It's not actually brush, it's cervical broom, right? So we have cervical broom and we have cytobrush. The thing about cervical broom and cytobrush, or the difference between IS spatula and cervical broom cytobrush, is simple. IS spatula was the conventional pap smear, which has been used for years together. Now we have a new type of pap smear called as a liquid based preparation, or LBC. These two are the thing which is used for liquid based preparation, LBC, or liquid based cytology, and this is used for conventional pap smear that is being done for years together, right? Why these two are important? Why these two are different? In liquid based preparation, actually we centrifuge and remove all the impurities. In a conventional pap smear, I won't have the impurities. So in microscopy, you'll see mucus, you'll see in lots of inflammatory cells and everything, right? Because of this, the adequacy level changes, and also we'll come to the fixative. Fixative is asked. Hello Amigo says that it's 90% alcohol is the fixative. How many of you accept that? 90 or 95 or 100. If you have three options, you won't have options like this. What would be a better one? Ethanol is the fixative which has been universally used. We don't use ether. Ether is inflammable. It has been long days back we used ether. We don't use ether anymore. It's ethanol, as close to as absolute alcohol. It's as close to as 100%. 95% ethanol is a preferred one. If you don't have absolute alcohol or 95% ethanol in the question, please look for isopropyl alcohol. Isopropyl alcohol is used in private laboratory. Government can easily get access to alcohol. Private labs cannot have it, right? 95% ethanol or an isopropyl alcohol is the best fixative for pap smear, right? Be it in cervical brush broom LBC or be it in conventional pap smear, right? The moment we do it, we need to have adequacy. How many cells do you think is adequate for a pap smear if in a conventional thing? Like how many squamous cells should I see in a pap smear to call it, okay, this is adequate? We need to see at least minimum of 8,000 to 12,000 squamous cell in a conventional smear, and I need to see at least a minimum of 5,000 cells, squamous cells, fine, in a LBC, right? Why I wanted you to know this is, you have already been asked questions on what is the adequacy for a thyroid FNAC. So if you have to go to the same basics, I'll definitely ask this as well. For a conventional pap smear, thoda extra cells is required because of all the impurities as well. But LBC, it's a pure thing. LBC is a short form which you have to know. Since it's pure, not much of muck particles we use, 5,000 is more than enough for me to call it adequate, right? So these are few things about pap smear, right? Now let's go to the next guide, FNAC. Fine needle aspiration cytology. Okay, this is the handle which is used for the examination. This is called an FNAC handle. So what we do in FNAC handle is, we just put the syringe on the FNAC handle. You can see the place for the syringe here, and we pull it. It gives negative pressure in order to pull it, right? And we put the needle on top of the syringe. You move into any structure and you make a smear out of it, like a normal first year may must have done, no, blood smear. Like that, you make a normal smear and then you do an FNAC, right? Tell me any organ which comes to your mind where FNAC is done. I want you guys to interact. Vicky, Almanur, Seth, Amigo, Anuj. Any organ where you think FNAC is still the gold standard or still the first line of investigation. There are multiple places where we did FNAC. Slowly we have removed everything. FNAC is must for me for thyroid. I need FNAC for thyroid by default, like Dharmesh said. Perfect. Breast, yes, a little bit with a pinch of doubt, because true cut biopsy has kind of almost replaced the breast FNAC, but still we do for some instances breast, but thyroid is inevitable, I do it, right? And one more thing which is commonly done is lymph node. To see whether lymph node is having metastasis or not, to see or confirm whether it's a tuberculous lymphadenopathy, we do FNAC, because see, remember, thyroid and breast are in this area. For me to take a biopsy, I need anesthetic fitness because there are major vessels there. I need a OT. That's why a very less invasive procedure of FNAC is being done, right? FNAC is also a cytological method, right? So mostly we use the blue intramuscular injection needle. If it's a very solid, strong lesion, we can go with the green needle, fine? Fixative. In FNAC, there are two types of stain done. Can anyone tell me what are stains done in FNAC? The moment any FNAC smear is done, we do two steps of stains. One is the conventional one, what we use for pap smear. We do Papanicolaou stain in FNAC also. The second one is we do something called 𝐒𝐿. 𝐒𝐿 or May-Grunwald 𝐒𝐿. Both are same. MGG or 𝐒𝐿 stain, both are same. Again, if the question is asking what's the fixative of FNAC, you have to see what stain I'm using. What's a fixative for FNAC in pap smear? The same, na? It's same 95% ethanol, right? If it is MGG ka fixative, MGG is an air dried smear. I don't use a fixative. We just make a smear, dry it, and then add GMSA to it, right? It's the same thing. If it's GMSA, it's air dried. I don't use a fixative at all. Then we stain it. If it's PAP, the routine same 95% ethanol stays there, right? So fixative is based on the stain what we use. It differs. Stains done, again it's PAP smear, and we do GMSA or May Grundwald GMSA. GMSA is the one which will be bluish in color, fine? And adequacy in thyroid. This is a PYQ. Come on, guys, tell me. When do you call this FNAC is adequate in a thyroid aspirate? You have to have minimum of 6 follicular groups with at least 10 follicular cells each group, right? This one I'll call it, this is an adequate biopsy, adequate FNAC. But exceptions are always there. If I can diagnose like a papillary carcinoma thyroid in one group is enough for me. If I can say, okay, amyloid is there. If amyloid is there, what do you guys think is the diagnosis? Lots of amyloid in a thyroid FNAC. Enough, na? I can definitely jump into this case of medullary carcinoma thyroid. I don't want that adequacy. Adequacy will always have a disclaimer, right? Nothing optimism, nothing will happen. Yes, the spread will be there. See, think that it's a papillary thyroid carcinoma. You're poking that. You have a report of papillary thyroid carcinoma. You will do a surgery within 7 to 10 days, right? No issues at all. Even worst case scenario, if it has issues, right? It will go to the same cervical node like what the papillary carcinoma thyroid goes. So not much of an issue. Yes, there is always an iatrogenic risk for any investigation. It can be superseded by doing a proper treatment very soon. Fine. Okay. So exceptions are there. Exceptions is if I can make a diagnosis like you have an intranuclear inclusion, that's enough for me to call it papillary carcinoma thyroid. If you have amyloid in the FNAC, that is enough for me to call it medullary carcinoma thyroid. If you have adequate evidence of diagnosis, I don't want to go to the adequacy criteria at all. And like Dharmesh said, I don't want you to repeat the statement, right? Everyone who's preparing knows this. FNAC cannot distinguish follicular adenoma of thyroid. Sorry, follicular carcinoma of thyroid because it's not cyst, it's CA. Okay, follicular carcinoma of thyroid because it needs capsular and vascular invasion. You need a post-operative specimen to diagnose follicular carcinoma of thyroid. This everyone knows that, right? Remember this always. Fine, perfect. Now let's go to the next investigation. Okay, this is frozen section. First and the foremost thing, can anyone tell me one use case of frozen section from your internship, from the time you have prepared? Frozen section is useful. You must have read definitely this in your breast classes. Sandeep sir must have definitely told you that in sentinel lymph node biopsy, frozen is very, very, very inevitable, right? Frozen section, this instrument is the frozen section instrument. We use the term cryostat. Cryostat is the name of the instrument, right? This is the chamber where you have the minus degrees centigrade, right? You have minus 20 and below, so it freezes immediately, right? And here we use, this is called as a chunk where you use a gel foam which will fix the tissue. There's a microtome. Microtome is something which will cut the tissue and then you make a slide out of it. Here, if the question is what is a fixative, can anyone tell me what's a fixative in frozen section? Actually, this will lead to one more question for us related to frozen section. Frozen May, there is no fixative. The temperature, the freezing point is the fixative, right? Here, there is no fixative. The temperature here acts as the fixative. What's fixation mean? Can anyone tell me what does fixation mean? We have been talking many things about fixatives, na? Fixation ka matlab is simple. If something can make me, let's say, prevent autolysis. If I take a tissue from the body, it will die. Na? That is autolysis. Fixation is the one which will prevent autolysis. That's all. And also second important thing, if I take something outside, it will also have infection risk. Also will prevent infections. Now remember, now imagine if I'm going to freeze something. Optimism, adhering to the tissue slide is the wrong answer. That's not the job of the fixative at all. If I freeze anything, you won't have infection. No, that's why we use dead bodies in freezers. Temperature lowering can make the entire cells inert. No reaction, no autolysis, no infection. That's how fridge works, right? Or reduced risk of infection. Fixative will prevent autolysis. Fixative will prevent infection. It is not for adherence at all, right? And a special stain which requires frozen section to be done. This is an INICET favorite. Which special stain requires definitely, okay, I need this to do the stain, I need frozen section. That is your fat stain. For doing oil red O and for doing your Sudan black B or Sudan black and its variants, I need a frozen section because the normal processing will remove fat. That's why it's clear in light microscopy. So we need a frozen section for that, right? This came in INICET. Do remember that, right? And also remember this, frozen cannot confirm diagnosis. I'll explain what this means because this was one of the all except answer in an INICET exam. Frozen section, now, if you have a lymph node of the axillary nodes, frozen, I can say cancer present, cancer absent. I cannot say whether it's IDC or lobular carcinoma or medullary carcinoma. I cannot say that. In your lymph node of the cervical region, I can say, cancer present, absent. I cannot say papillary carcinoma, medullary carcinoma or squamous cell carcinoma, right? So it cannot pinpoint diagnosis. It can say, yes, tumor present, absent, margins of the tumor involved by the tumor or not involved by the tumor. It cannot diagnose. It cannot pinpoint saying, yeah, adenocarcinoma, it's squamous cell carcinoma, small cell carcinoma. It cannot say that. That's one disadvantage of frozen section. Fine. Last but not the least, we'll go to electron microscopy. There's one more microscopy as well. We'll come to that, right? Can anyone tell me at least one use case of electron microscopy? This entire exercise of reading electron microscopy for an undergraduate, I don't think it's much required. We really don't use electron microscope except for very, very rare case of kidney biopsy. We do, right? Minimal chain disease you must have read, but who's going to do electron microscopy? I can diagnose it clinically. Now, electron microscope, the fixative is required. We have glutaraldehyde as fixative. There's a very commonly used fixative. We have few more things. Osmium tetroxide as fixative. Okay, that also is an important thing. Okay, electron microscopy, there are two types. We need not go into the depths of it for now. We just remember, okay, this is electron microscopy, at least for theoretical purpose. Yes, glomerulonephritis has a use case of electron microscopy. Most of the electron microscopic evidences are in research purposes. In CNS, we used during research purposes electron microscopy. For diagnosis, very, very, very limited use case for electron microscopy, right? Just you have to remember fixative. If the question gets repeated, you have to write that. Fine. Okay. Next, one more microscopy. Fluorescent microscopy. Tell me, where do we use fluorescent microscopy? There are two things in fluorescent microscopy. One is direct immunofluorescence, DIF. The other is indirect immunofluorescence. Fine. Indirect immunofluorescence is not useful for diagnosis. Whatever slides you see, what's the color of fluorescent microscopy or IF, immunofluorescence? You have the black and the green color. No, you must have seen in the kidney biopsy, black green image, right? That is fluorescent microscopy. All the diagnostic microscopies done is direct immunofluorescence or DIF, right? In that we have a stain. The stain is important. Okay, I do have a component for that, the black green one, right? Stain, the green color is the positive stain, and most of the time the green color is FITC. It's a cyanide dye. Cyanide always has a greenish color, right? Fluorescent, okay, it's fluorescent isothiocyanide. I'm telling this for the only reason that last time, a couple of years back, you had a question on what will give brown color in IHC. DAB, right? Diaminobenzene, right? Similar way, if they ask what will give green color in a fluorescent microscopy, it's FITC, fluorescent isothiocyanide. There are red colors, there are yellow colors also, but common 99% is this only used. We'll remember that alone, right? What's a fixative for fluorescent microscopy? Same template we are reading for everything, right? Fixative, either I can use saline, that's a commonly done fixative. If my hospital has fluorescent microscopy, I take a biopsy, put in saline, send to the hospital. If it's not having, okay, I have to send to a referral lab, right? I use a medium called as Mitchell's medium. Fine. Mitchell's medium is a fixative if the test will be done like 6-7 hours later. For a reference lab, it has to go. I use Mitchell's medium, right? Frozen or a very non-fixed tissue can also be useful for fluorescent microscopy, right? And tell me any use cases of fluorescent microscopy. I'll tell one use case, you tell the rest. I'll tell the easiest one. In case of glomerulonephritis, we do use fluorescent microscopy, right? Anything else? Anything else? Come on, guys. You know the answer. Jesse sir must have told this for sure in dermatology. You must remember this. You'll have an appearance which looks like this, na? Fishnet, like we do use for bullous disorders, right? In skin, at least for an undergraduate perspective, we do use it for bullous lesions of the skin, right? You have pemphigus vulgaris, bullous pemphigoid, IgA pemphigoid, multiple places we do use, right? And also we do use for immunological studies. When I say immunological, you must definitely remember this image. In SLE, right, we have the rim pattern, nucleolar pattern, diffuse pattern, speckled pattern. All these are immunofluorescence only. Wherever you have the green background, it's an immunofluorescence. These are the commonly used one for immunofluorescence, right? So now, if just an image is given, what type of microscopy is it? Is it light microscopy? Is it electron microscopy? It is immunofluorescence. One of the easiest way to identify is immunofluorescence microscopy always has a light source from here. If you have a light source coming from above, in a normal microscope, light source always from below. You must have seen in your colleges, right? It'll always come from here, right? Here, yes, I'll have a light source below, but I'll also have a light source coming from above, right? Now, if you look at this, I have a light source coming from above, and also the specimen is here. So it will reflect. The reason it's becoming black in color is the mirror, what we use is filters every other wavelength of light. So only, I'm seeing only green and black or red and black. Two colors only, right? That also was a question, a very old question. Dichroic mirror, it's used in case of fluorescent microscopy, which can filter two specific wavelengths of whatever we fit. If it's red and green, or black and green, or yellow and green, sometimes even red and yellow, right? Something of that sort. So dichroic mirror is a very important component of fluorescent microscopy. It is asked, and if you have a light source from the top, fluorescent microscopy, and we know the use cases, fine. Okay, let's slowly move to histopathology. This is called a vacuum tissue processor. How many of you during internship have taken biopsies and given to the lab? All of you must have, right? Most important thing of an intern is to give the samples. The moment you give the sample, I cannot take a slide immediately. It's a sample, it's flexible. So I have to make lots of changes in the sample, right? All the tissue, all the biopsies are processed in a tissue processor, a minimum of 17 to 24 hours. There'll be an overnight processing. And the reason for processing is simple. In this processing, yes, fixative is one of the important component. It will fix the tissue. It will make the tissue thoda hard, and it will be easy to section. Sectioning is the next step. Once the tissue is processed, then we use an instrument called as a microtome. This also is a basic instrument of pathology. In microtome, we section. Most of the section should be from 4 to 10 micron thickness. For lymphomas, I use much thinner. For other tissues, I can go up to 10 micron, right? Once it is done, then yes, we'll put it on a slide, and then we use stains. Whatever stain we want, we use it, right? The commonly done is histopathological examination, used in hematoxylin, we can use in PAS, we can do in oil redo, whatever it is, we will do after that only, fine? So this is the normal routine which is done. In this fixation, in this entire processing, we use gradations of alcohol. Lots of gradings. We have 100%, 90%, 70% to remove all the water out of it, right? That is very important. Then finally, we use something called xylene. Remember this is an important thing for a pathologist, which is called a clearing agent. So now I removed water from the tissue, but there is alcohol inside there. Now I have to remove the alcohol also. Xylene clears everything, right? Clearing agent, xylene clears the entire alcohol, which makes it perfectly crystal clear, only the tissue, so that it's easy for me to stain and to have a look at it, right? This is a routine processing. What happens? The reason for me to include the lab part is, fortunately or unfortunately, almost alternative INICET has one question on the lab part, a lab pathology, which is not covered in the hardcore pathology. If you are preparing for INICET, there's something which you have to know, okay? Just before finishing, we'll look at the fixatives and stains. We look at the stains which is used in hematology. We know the stains which is used in histopathology, right? It's used in hematoxylin. Can anyone tell me what are the stains used in hematology? Stains in hemat. I think it must be there down also. I'm just covering it here because we are covering the rest of it. In hemat, we have two stains. One is Leishman stain. Fine. The normal stain, what you see, the red color and everything, The other is the supravital stain, new methylene blue stain. Fine. We don't use GIMSA Sai. GIMSA is not a common stain used. We might use sometimes for bone marrow aspirates, but Leishman is the commonest stain used, and new methylene blue, that's a supravital stain, which is also used. Fine. We'll see what a supravital means, what's the fixative in Leishman and new methylene blue very, very soon. Fine. Okay. Now let's look at other stains. This is something which I want you to answer because you guys already know this, right? Tell me, where do we use this? Tell me cases where we use it. Masson-Fontana is a stain which will highlight the pigment blackish brown in color. It's a stain useful for melanin. Last exam, previous exam, we had a twist of this question. Everyone knows, use case for Masson-Fontana is melanoma, it will be positive, right? And also, it will be positive in nevus or nevi. That's a benign tumor of melanocytes, right? What was the question in last exam? It's a pigment stain, right? It's a pigment stain. It's very, very simple to say it's a pigment stain. But there's one more thing which was added last exam. They asked a question on which of the following is a stain for fungus. But unfortunately, PAS was not there, GMS was not there. And please do remember that if it's a pigmented fungi, there's a recent repeat, you have to know about it. If it's a pigmented fungus, you must have read about pigmented fungus, na? Right? Black color pigments. That black color pigments will be positive for Masson-Fontana because that's all the same melanin, no? We have a disease called as pheohyphomycosis, which is pigmented stains. You must have read in dermatology, right? All these pigmented fungi which produces melanin will be positive for Masson-Fontana. Do remember them, right? We call it argentaphin stains and it will stain the argentaphin granules. Fine? Okay. Then PAS. PAS is periodic acid shift. PAS, it's positive in many, many places. Can anyone comment on which all places where you can see PAS positivity? Apart from what is written on the above. Any other thing apart from what is written there, which is PAS positive? PAS is definitely positive in glycogen. It's positive in quite a few mucopolysaccharides. It's positive for the fungus. The hyphae of the fungus will be positive for it. PAS is also positive for, this is an old PYQ, na? Barrett's esophagus may. It stains mucin. It's actually a stain for neutral variant of mucin, right? Acid mucin ka stain kaun hai? What's the acid mucin stains? That's your Alcian blue, right? This is most of a neutral mucin stain, but it stains mucin. It also stains protein, right? It stains multiple things per iodic acid shift, and the color of the stain is magenta color. If it's magenta color, it is a positive thing which you have to remember. Fine. Okay. Done. Now, yes, Utkarsh, for an ALL blast also it stains. The reason I didn't put ALL blast is in an ALL blast, it stains glycogen in the ALL blast. So it's glycogen stain, that's all, right? So PAS use case now. In glycogen, it's not just PAS, it's a modification. Any question which says PAS positive and diastase sensitive, this is specifically for glycogen. Okay? If a question says, it's a protein ka stain. So I won't say it's protein, obviously it's an MCQ exam. So I'll say PAS positive, I will call it diastase resistant. If it's diastase resistant, it's a protein ka stain. Okay, it's positive for protein, right? Perfect, right? Amazing. So how can I use this in exam? INICET is taking a fact, making a scenario-based question. I'll give you a simple scenario. I want you guys to answer it, right? 45-year-old person having a declining renal function came to the OPD and a renal biopsy was done. In the renal biopsy, in the proximal convoluted tubules, there are clear vacuoles, which is positive for PAS and diastase sensitive. What is your diagnosis? This is integrated medicine. Now, what is your diagnosis? Knowing fact is not enough these days to clear an exam. So don't memorize. You have to know how to apply the fact. So this PAS positive diastase sensitive is a glycogen. Why will glycogen be then PCT? Only when glucose is excreted. That's a simple case of diabetic nephropathy. Now, put up your hands if you can or if you have heard about Armani-Epstein lesion in diabetes. Tell yes. Have you heard about Armani-Epstein lesion? You must have, na? Armani-Epstein lesion is a finding in diabetic nephropathy. Everyone must have read. This is the lacunae. The lacuna is not knowing, it's not about not knowing facts. Everyone knows the facts. Everyone has heard about it. The same Armani-Epstein lesion I have put as a scenario-based question. The scenario is this. Armani-Epstein lesion is nothing but glycogen cut deposit in PCT, right? So I can use that. So if this is positive in PCT, that is nothing but Armani-Epstein lesion. That is nothing but your diabetic nephropathy. Okay, so I can create multiple questions like this. PAS positive, diastase sensitive, happening in the heart, Pompey's disease, happening in skeletal muscle, McArdle syndrome, happening in liver, 𝐌𝐞𝐝 disease. Again, correlation of biochemistry, correlation of clinical medicine, correlation of your pathology. Okay, same way, PAS positive diastase resistance seen in a liver biopsy. This I'm sure you must have read about it. Alpha-1 antitrypsin deficiency. You'll have multiple globules of fat, globules of protein in the liver in case of alpha-1 antitrypsin. Fine, perfect. Simple guy. Next stain, oil redo, neutral fat, lipids, it'll stain. This is your oil redo. We already read a part of it. What's a fixative required here? We need a frozen section here, right? Both Sudan black B and oil redo are stains for fat. In H&E, fat is always clear. The reason for clear is fat is being washed away during processing. It will be completely washed away during processing of a tissue. That's the reason fat is completely clear in case of an light microscopy. Fine. Okay. Commonly used places, fatty liver, alcoholic, non-alcoholic. What is the most common cause? The common use case where we diagnose is in liver biopsy. The most common cause of fatty liver is not alcoholic hepatitis anymore. It's non-alcoholic fatty liver disease. Please change the facts. Facts do change. Do remember them. And the most important clue, I'll give you a clue. Possibly this might come in an exam, right? Let's say it's a child, right? And in liver biopsy, you see microvesicular steatosis, tiny accumulation of fat inside the liver biopsy. Can anyone tell me what could be the most probable diagnosis? It's a very classical symptom. Fat, microvesicular steatosis. Anyone? It is. If I add one more thing, you'll say this happened after ingesting aspirin. It's a classical case of Reye's syndrome. Do remember, drug-induced hepatitis will always have your microvesicular steatosis. Do remember that. That's one of the important clues you have to remember. Fine? Perfect. Done. Let's go to the next guy. Perspiration blue. It will be staining for hemosiderin. Mostly pearls will stain hemosiderin. Pearls will not stain generally ferritin. But if I have to say that ferritin will be stained, but if you have to go for an MCQ, it stains predominantly hemosiderin, not ferritin. Ferritin is storage form, normal form. We don't look into it much, right? So I'll give you different scenarios. You guys have to tell me the diagnosis, where all I can use this, okay? All of them are Pearls positive cases. You tell me the diagnosis. Pearls positive in a liver biopsy. Come on to the diagnosis. These are simple, easy ones. Pearls positive in the form of a ring in a erythroblast in bone marrow. Come on, tell me the diagnosis. Pearls positive in a lung biopsy in a macrophage. Come on, tell me the diagnosis. This came in the last exam also. You guys have to comment. Pearls positive in a lung biopsy. The patient is a worker working in cement industry. Come on, tell me the diagnosis. It's a simple ones, no? Pearls liver, I'll always think of hemochromatosis. Could be hemochromatosis, could be hemosiderosis. I'll have to think of based on the history available, hereditary or acquired, post thalassemia, multiple blood transfusion, right? Pearls ring formation in your liver, in your bone marrow biopsy, you think of sideroblastic anemia. Possible. That's sideroblast, no? Sideroblastic anemia. Or it's also seen in myelodysplastic syndrome. Lung biopsy, macrophages, these are nothing but your heart failure cells. Last exam had a question on heart failure cells, NEET exam. It's a very simple question. Many of you ignored it. Simple case of pulmonary edema. You'll have heart failure cells, right? Lung biopsy, some of you guys said, it's a classical example of asbestos bodies, ferruginous bodies, same pearls. One thing, I can go into multiple places, apply and ask you multiple questions, right? Perfect. Next is your favorite one, right? This mnemonic everyone in pathology department knows, which is 𝐂𝐂𝐿𝐶IUM. See, few mnemonics are like forever. Like she looks too pretty, try to catch her. It's going on for generations. Like that, this also is going on for generations. It's 𝐶𝐂𝐝, 𝐌𝐞𝐝, and AL for alizarin red. Alizarin red is a specific stain. 𝐌𝐞𝐝 is not a specific stain. Alizarin red stains elemental calcium. Elemental calcium ka matlab, it will stain Ca2+, not salts, not calcium phosphate, not calcium carbonate. 𝐌𝐞𝐝 will stain calcium phosphate, calcium carbonate. This is most commonly done, but not that specific. If the question is which is specific, which is best for calcium, alizarin red is the best for calcium, but it's expensive. We don't use that anymore, right? So 𝐌𝐞𝐝 is widely distributed and this is the common one used. And 𝐌𝐞𝐝 will pick up the stains, the calcium deposits, blackish in color, right? This is the HNE. It's little bit bluish in color. Can anyone tell me what's the diagnosis here? You must be jumping to the diagnosis. What's the diagnosis in this? It's a classical case of Psammoma bodies, right? It's a classical case of Psammoma bodies, the world appearance of calcium deposit, right? Can anyone tell me what diagnosis is this? This is a 𝐌𝐞𝐝 stain, okay? I'll give you a clue where you see calcium in blood vessel. The blood vessel wall, I'm seeing calcium. Can anyone tell me what's the diagnosis? It's an old age finding. Have you heard about a condition called as Monkey-Burke's arteriosclerosis or Monkey-Burke's medial calcification? This is Monkey-Burke's, right? This is Monkey-Burke's calcification. That's something, calcium deposits seen in old age in the blood vessel wall. Fine? Okay? Perfect. Let's go to the next guy. Congo red. Great, Priyadarshini. Yes, you are right. Congo red. Where do you see Congo red? Congo red, there are few important questions which keeps coming in Congo red. What's the color of Congo red in fluorescent microscopy? What's the color of Congo red in your light microscopy and everything? Congo red is a very good stain for amyloid. Fine. Once an AIMS exam asked how Congo red works. Amyloids are non-branching fibrils. Na? Amyloids are non-branching fibrils of your beta pleated sheets, right? That's what amyloid is, the secondary form of protein. Congo red na binds these things, so it kind of twists them, gives a refraction. Congo red binds the gap between two unbranched, they make it branched. That's why Congo red is useful and gives a fluorescent image, right? So if a question comes, we have done Congo red, these are very important, so listen and answer. I am seeing a light microscopy. What is the color of amyloid? And I'm using a polarized microscopy. What is the color of amyloid? Can anyone tell me what's the color of amyloid in light microscopy and also then in polarized microscopy? It's a simple ones. Na? Light microscopy, the color is simple. You'll have your salmon pink color, hai na? Once the same amyloid in Congo red, once it moves to polarized microscopy, whatever you're seeing, you will see the classical apple green birefringence, right? Okay. Now, polarized microscopy is used in 3 places in pathology for an entrance preparing student, right? It has multiple use cases, but polarized microscopy can be used in 3 places, and all these 3 places can come in an exam. One, obviously, is an amyloid. We know it's the apple green birefringence there in amyloid. Second, it's useful in both your 𝐿 and your pseudo-𝐿 arthritis. At least 𝐿 you have to know. In 𝐿 arthritis, you will have needle-shaped crystals, negative birefringence. Okay? Remember like this. Needle, NN, right? Needle-shaped crystals, negative birefringence is classical for 𝐿 arthritis in your joints. What's the commonest joint where 𝐿 arthritis is involved? Can anyone comment on that? Third, it's also used in silicosis. Silica particles are positively birefringent particles. Okay. In occupational lung disease, in lung, silica particles are positively birefringent, right? Perfect. You'll have it. First, metatarsobphalangeal joint. That's the commonest place where 𝐿 arthritis can happen, but it can happen in every joint in the body. Fine. Okay. So these are the 3 other use cases of polarized microscopy. Fine. Great. Too. Okay, and amyloid is something classical. Other two things also I want you guys to know. It's important for you to know it. Fine. Okay, and since we are here, we'll just touch base on pseudogout also. Pseudogout came once in an exam. There are few important things which you have to remember regarding pseudogout. First, it's most commonly seen in knee joints, not in first metatarsophalangeal joint. Second, there are few important risk factors. Remember this at least because it's a PYQ. Hemochromatosis is an important risk factor for pseudogouty arthritis. Do remember that. It's a calcium pyrophosphate dehydrogenase crystals and it'll have rhomboid shape and also it'll be positively birefringent. Fine, it's not needle shape, it's a rhomboid shape, CPPD crystals, and in your gout, it's a sodium urate crystals. Fine. So these are few important things you have to know about gout and pseudogouty arthritis. Okay, perfect, done. Then let's come to next stain, reticulin. Right, where all you can use reticulin stain? This came in a very old image. They gave an image of reticulin and asked what slide this is. It's a classical slide of liver biopsy. If you can look, there's a central vein. There's actually the portal triad. Liver is rich in reticular fibers. Fine. Reticulin background can be green in color or background can be white in color. Reticulin, it's a silver based stain. So reticulin will be staining everything black in color. It will stain anything black color when they are very thin fibers. It will be stained black in color. That's a base of reticulin, right? So reticulin stain, this was also a PYQ. I am sure you know this. Which of the following organs has reticulin stain except? Options are lymph node, liver, spleen, bone marrow, thymus. Which of these will not have reticulin stain? Reticular fibers are seen in which organs, which tissues? We see them in reticuloendothelial system. Hai na? That's why we name them reticuloendothelial system. Liver, spleen, bone marrow, thymus, lymph node are all reticuloendothelial system because they have reticulin filmic. But it is exception. Exceptions are MCQ. Not seen in thymus. Right? Thymus lacks reticular fibers. That's the reason thymus can disappear. If reticular fibers are there, thymus cannot disappear. This is normal, right? So where do you use abnormality? In pathological conditions, where do you use reticulin? Whenever all these organs becomes fibrosed, I use reticular fibers, right? Simple case, I can use them in cirrhosis. To find the nodules, we use reticular fibers. You can use them in myelofibrosis. Bone marrow fibrosis, we use reticular fibers. Again, it's just to find, there's excess fibrosis there, so we can call it liver fibrosis or bone marrow fibrosis. Okay, that's the base of reticular fibers. It's seen normally in liver, it's seen normally in every reticuloendothelial system except thymus. Do remember that, right? And let's come to GMS. GMS full form is Gomori methanamine silver, right? Or Grocott Gomori methanamine silver. Again, it's a silver based stain. Please remember, anything silver based, it'll always be black in color in microscopy. Background is black because silver, your mom must have told, now if you keep silver in the oxidized state, it'll become black in color, right? Perfect. GMS is a very, very, very specific stain for fungus. It's undoubtedly a fungal stain. It is specific for fungus. PAS is also a fungal stain, not that much specific because it's not that much clear, right? What all questions have come with respect to GMS stain in fungus? First is aspergillus. How does aspergillus look in a GMS stain? It'll have the classical 45-degree septate hyphae, right? 45-degree septate hyphae present. It's aspergillus. Everyone knows that, right? Then I can pick up mucor also with this. Mucor, the ends are important. The bulbous ends, the ends are a bit bulged. That's a very important finding for mucor, right? Could be a 90-degree and a bulbous end. That is very, very important for mucor. Septate, aseptate is based on multiple subtypes of mucor, but generally the 90-degree and bulbous end is important. And obviously history, immunocompromised stage, destroying the nasal cavity, going into the brain, angio-invasive, all those are important for me to not to miss as well. Fine, okay. Recently in one more exam, one more important finding was asked. I am sure you know, right? Perfect, like Dharmesh said, I have a crushed ping pong ball appearance. That also is GMS. A crushed ping pong ball appearance. Is it seen in crypto or anyone else wants to change their answer? It's seen in sputum. Is it seen in crypto or is it seen in pneumocystis carinii pneumonia. So findings in pneumocystis jirovecii or pneumocystis carinii pneumonia, you will have something like this. It's like a crushed ping pong appearance, right? Bronchoalveolar lavage, or in your sputum microscopy, you can see crushed ping pong appearance in pneumocystis carinii, not in cryptodermis. Fine. So these are use cases or application of GMS based questions. GM is a fungal stain, a very good specific fungal stain. Fine. Okay. Fine. Now at the same time, PAS is also a fungal stain, right? At the same time, there's one more black color stain which stains a slender bacilli. I'll tell the bacilli, you tell me what stain it is. The stain calls the bacilli calls H. pylori. H. pylori is a very slender bacilli. Na? To stain, I need a silver base. And there's one more slender bacilli called as Treponema pallidum. It's also very, very slender, right? S-shaped slender organism. For both these things, I need a stain which is also a silver stain. Anyone? We have a common stain called as Werthenstari. Werthenstari is a silver stain which is used to identify your H. pylori gastritis and a syphilitic organism, maybe in a canker or maybe in a tertiary syphilis, wherever you want, I can pick them up, right? It's a silver stain, Werthenstari. Sometimes, if Werthenstari is not there in the option, there's one more method of silver stain called as Steiner silver. Remember this? It is primarily for H. pylori. But if Werthenstari is there, I'll definitely go with that. Fine. Okay, this is silver based stain, right? Last stain here. Anyone? Where do you think this is used? Not that important. But again, I said, now INICET has few. They have that sense of pride. Okay, I'm from AIMS. I will do test where it is not done other ways. Laxal fast blue is something. It's a stain for myelin. So where do we use them? We use them to identify demyelinating disorders. So theoretically, it will be, see, this is positive myelin. Myelin is there. In this area, I don't see the blue color. Nah. Here, there is negativity. Demyelinating has happened. Demyelination has happened, right? Theoretically, yes, I can use this for multiple sclerosis. That'll be demyelinating. Nah? Theoretically, I can use it for JC virus. You must have read about multifocal demyelinating disorder, JC virus disorder, right? Theoretically. But you tell me, which is better for demyelination? MRI or take a brain biopsy and do Laxal fast blue? MRI is better. Na? This is just for INICET. They'll have, I can also diagnose multiple sclerosis. Obviously, anyone can diagnose everything. Na? But what is important practically is to see which is comfortable for the patient. We don't use this. Theoretically, we don't use this. But in some conditions where it is not able to diagnose or it's a post-mortem diagnosis, we might use this for sure. Fine. No one does Laxal fast blue in real life, but people are hell-bent on it because it's an INICET product, right? Okay. Now, let's go to your special stains or the markers. We're done with special stains. We know the normal HNE. We know the lab counterpart, right? Now, IHC. The counter stain uses DAB. DAB is diaminobenzene. This is the commonest counter stain used in IHCs. That's the reason most of the IHCs will be brownish in color. Brown color is positive. This came in an older exam. Don't ignore that, right? Now, in the left-hand side, there are few commonly asked IHCs written. In the right-hand side, you are going to help me to say what is the most common diagnosis. This now we'll look into it. CK7, CK20 panel, it's been asked. The primary use case is to differentiate the site of origin. If you have a metastatic deposit, it has come from this side or that side. Easy clue to remember. We'll look at the flowchart soon. Easy clue to remember. CK7 is positive in upper aerodigestive tract. This will make your life much easier. Upper aerodigestive ka matlab above the ligament of Treitz, entire GI and also lungs. Upper aerodigestive, it will be positive, right? CK20 will be positive. There's one more marker called as CDX2. Both of them will be positive in lower GI tract. Anything below ligaments of Treitz, colon, rectum, anywhere, your CK20 will be positive, right? This is something basic which you have to remember. Fine. Om Patak. Not right place to discuss. Finish your MD dermatology. You will have multiple opportunities available, right? Okay, TTF1. Where do you see them? Fastest finger first. TTF1. It's positive in lung, adenocarcinoma. Fine. ERPR, you know the answer, right? Lung adenocarcinoma. Primary lung adenocarcinoma is positive. If a question changes, it also is positive for thyroid carcinoma. New things keep on cropping up. Now, TTF ka expansion is thyroid transcription factor 1. TTF is thyroid transcription factor 1. So obviously it's positive in every thyroid carcinoma. Though we don't use it, it's positive. Fine. ERPR, breast cancer. You'll never doubt it. ERPR is also positive in type 1 endometrial carcinoma. So also positive in type 1 endometrial carcinoma, right? Okay. HER2/neu or ERBB2, it's positive again in your breast cancer. Since we have ERBB2, we have to talk about ERBB1. Na? ERBB1. What's the other name for ERBB1? It is EGFR. It's also positive in primary lung adenocarcinoma. Fine. Okay. Prostatic origin. PSA is a commonly done one, right? The only disadvantage of PSA is positive in normal prostate, also neoplastic prostate. I cannot differentiate this gland is normal, benign or malignant. But ama karna is bit important. It's positive in malignant glands. It's an important thing. You have to remember it. It's definitely positive in malignant glands of prostate. So if you have a metastasis, can anyone, again a related question, which part of the body prostate cancer can undergo metastasis? Which part of the body prostate cancer can undergo metastasis? Bone, na? If you have a osteosclerotic metastasis in the vertebrae bone, we think of prostate. I take a biopsy and I say AMACR positive, I can say, it's a prostatic carcinoma, right? You can easily help me to diagnose them, right? Chromogranin synaptophysin is positive for every neuroendocrine tumor. Remember it. For every neuroendocrine tumor, it's positive. Could be positive for medullary carcinoma thyroid, your neuroblastomas, pheochromocytomas, the neuroendocrine origin, that's all. It will be positive for carcinoid, it will be positive for pheochromocytoma, it will be positive for neuroblastomas. It's for neuroendocrine origin. Anything originated from neuroendocrine tumor, it will be positive. Even medullary carcinoma thyroid is neuroendocrine origin. There are few more things I can generalize like this. There's one classical light microscopic finding, positive for carcinoid. Can anyone tell me? There's a pattern. It has different dark light blue color, multiple pattern. We call it salt and pepper chromatin. If you see this salt and pepper chromatin in a question, it is neuroendocrine. If you see synaptophysin chromogranin, it is neuroendocrine. In electron microscopy, if you see a finding, neurosecretory granules are seen, it is neuroendocrine. There will be black color, dense black color granules that is classical for neuroendocrine tumors. Okay, all these are classical clues. If any of them I see, look at the options, whichever is neuroendocrine, which will fill into that. Fine. Ewing's bar peanut. Peanut is an older term. Ewing's also slowly moving to older term. The latest term is we call it undifferentiated carcinomas. Fine. Ewing's now has a history of change of markers. One of the most useless markers is CD99 or MYC2. It's been discarded from practicing pathology CD19 for almost 15 years. No one uses that. It's a very non-specific marker. But still, MCQ is stuck on CD99. That's how old your MCQs are, right? It's still there, positive, but very, very, very non-specific marker. It's positive for multiple other tumors, right? So what we did was, from CD99, we moved to a better marker, which is called as FLY1. Okay? FLY1 was a very decent marker. But still, FLY1 had some problem. 10% of beings were negative of FLY1. Then came new marker. This is the latest marker. Do remember that NKX 2.2 is one of the most important and the latest marker for Ewing sarcoma. Agar this is positive, I don't even want fish, because we do fish in Ewings. Now, close to 95% of the tumors above that will be positive for NKX 2.2, which is the latest marker which has been used for Ewing sarcoma. I'm telling you the latest marker because for INICET. Otherwise, I have stopped with this for NEET, but NKX 2.2 is something which you have to remember by default. Fine. Okay. CD117, Dodge 1. GIST, na? Which is the most commonly done in GIST? Most commonly done marker in GIST. CD117 or Dodge 1? What do you think? Obviously CD117. Na? Most commonly done marker, Dodge 1 is a very, very, very specific marker of GIST. Don't memorize. The moment you start memorizing, we lose everything. Dodge ka full form is discovered on GIST first. That is Dodge 1. This is not my mnemonic. That's how the tumor marker is named. Discovered on GIST first. So obviously it's a specific marker for GIST, right? Okay. Melanocyte again, same. S100 is a very sensitive marker used for melanocytes or melanin or nevus. These both are very, very specific marker used for melanocytic or pigmented lesions. Your HMB45, HMB45 ka full form is human melanin black 45. And melan-A, very specific marker useful for your melanocytic lesions, right? And B cell, there's a B cell marker, and CD3 is a pan T cell marker. 3 is much more important marker than 4 and 8 because it will be positive in both CD4 and CD8 positive, and 1920, both of them can be positive for almost every B cell lesion, right? Ki67 is MIB1 index. It's a proliferating index. It tells how many percent of the cells in the tumor is proliferating. Can anyone tell me where do we use Ki67? Any one place which comes to your mind where we use Ki67? Any one case? Ki67, 100% Ki67 is a finding seen in Burkitt's lymphoma. Something which is used. Ki67 is a prognostic scoring. Ki67 of more than 14% is something which is useful in the luminal categorization. That's in a luminal B of an breast cancer. Fine. In case of luminal B of breast cancer, it is useful. Fine. There are few places where it's been used. Perfect, guys. Chaitanya and Sai, it's great. These are two places, at least from undergraduate perspective, I want you guys to know, right? Perfect. Classical Hodgkin's lymphoma, you know that it is CD15 positive, CD30 positive. What should be PAX5? PAX5 should be weak. It should be weak for a classical Hodgkin's lymphoma. If it's strong, it is not classical Hodgkin's lymphoma. NLPHL, which is a non-classical variant, 20 positive, 45 positive. Please add on to that CD15, CD30 should be negative, and PAX5 should be strong. If it's not strong, it is not NLPHL. PAX5 is actually the differentiating pointer. If you want to do one marker, do PAX5. Weak, classical, strong, non-classical, or the nodular lymphocyte predominant Hodgkin's lymphoma, right? Now let's come to the table. This table has been making grounds. Now, every PYQ discussion, this table will be there. This table is from Harrison. 720 ka use case. I told you to remember one. Anything upper aerodigestive, 7 is positive, right? Upper aerodigestive, 7 is positive. That's an easier way to remember. Now, let's see where are CK7 positive and CK20 negative. Upper aerodigestive, lung. I won't consider breast to be upper aerodigestive, not digestive or in the respiratory pathway, but embryologically comes in the same place, right? Breast, thyroid, upper aerodigestive. Ignore this. I'll tell you why to ignore. Ignore this also. Salivary gland, it's digestive, right? Ignore this, ignore this. Remember only these. I'll tell you why remember only these. Cholangiopancreatic, na, it's seen here also. It overlaps. Whichever is overlapping, whichever is gray area, not needed for undergraduate. For undergraduate, I need to read only which is not overlapping. Why no cervical endometrium? I don't diagnose endometrium with CK7, ERPR, cervical with P16, right? I don't diagnose them with CK7 or CK20. We don't do it. That's why. And these are not 100%. Cholangio and pancreatic can have both 7 positive, 20 positive, 7 positive, 20 negative also. So if it is not in the black or white area, gray zone, it is not good for not required for undergraduate, right? CK7 positive, 20 positive. Okay. Urothelial, ovarian. That's all. Both positive. Now let's take CK20 positive, 7 negative. Lower GAT, na? Colorectal, lower GAT. Merkel, it's primarily for MCQs. It will be CK20 dot-like positivity. Dot-like CK20 positive is Merkel cell carcinoma. Do remember them, especially for INICET might come, right? Both negative. Which all to remember, okay? I don't want you to remember prostatic carcinoma, squamous cell carcinoma, head and neck. Head and neck, most of them are squamous cell carcinoma only. Because squamous cell carcinoma, we have a different marker. Now, squamous cell carcinoma, we have P40, P63. I don't even come into CK7s, right? But renal and hepatocellular carcinoma, these are two things which I want you to remember for both negative. Fine. Easy way to remember, 7 positive, upper aerodigestive. Anything in the upper GIT, breast, lung, salivary glands, thyroid. Again, upper aerodigestive. Lower GIT is 20, that's colorectal, Merkel. Both negative, liver and prostate. So liver and renal, prostate also, but not much required because PSA is used. Liver and renal, both negative, right? Urothelial and ovarian, both positive. Fine. But yes, there's a very high likely possibility question can come in this flowchart. Please do read them. Take this screenshot, put it in your wallpaper, keep it there for 1-2 days. You will definitely remember them, right? Okay. Now we know most of the stains needed, most of the normal fixative used, most of the normal instruments used, right? That forms the base. Agar if base is clear, we can easily build on to it. Now let's take next 1 hour for RBC disorders. Fine. Okay. Now tell me what all comes to your mind with respect to hematology. Next few minutes, I want you guys to comment. What all important questions comes to your mind with respect to hematology? What all comes to your mind? See, hematology, you will have questions on both RBC disorders, WBC disorders. Obviously, Chaitanya, that includes everything. Na? Platelets, the PT-APTT has been kind of some places it's been very importantly focused in few INICET, some places there will be no question at all. But RBC, WBC is what we are going to focus more, and we'll definitely cover that in a systematic manner. Image based. If I have this image, what do I think of? What are the investigations I do? What are the clinical scenario we are going to look for, right? But before that, basics. Leishman stain is the commonly done stain, and the fixator for Leishman stain is acetone-free methanol. This is very, very important. Acetone should not be there. Because if acetone is there, they cause hemolysis. It's a methyl alcohol, but it should be acetone-free. Acetone-free methanol, diagnostic of it, right? Then, new methylene blue, which is supravital stain, which is stain used for reticulocyte count. It's a reticulocyte stain. They are called as supravital because they don't have fixative. There's no fixative in new methylene blue stain, which means if I make a smear today for reticulocyte, 2 days later, I can't use this because every cell will die. No fixative. It has to be made immediately, it has to be counted immediately and reported immediately. You can't store it. But Leishman, you can store it by default. Someone said 𝐒𝐿 as well. Yes. 𝐒𝐿 is used primarily for a bone marrow investigation. Bone marrow aspirate, we do use 𝐒𝐿. But for routine peripheral smear, we don't use 𝐒𝐿. Supravital stains, yeah. Chaitanya, you are asking what does supravital mean, or you want to ask whether it's also called as live stains. If you want to call live stains, you call it live stains. It does not have a fixator, so I have to report today, stain today, I'll have to report immediately. Fine? Okay. Now, what is this slide? The answer is below only. But how do you pick up this? If a question says, I see spherocytes in a smear, or if an image is given with spherocytes. So first question is, how do you pick up spherocytes? Spherocytes are very simple to pick up, right? A smaller RBC, a darker RBC, and the most important thing is there is no central pallor. A smaller, darker RBC without a central pallor, I think of spherocyte, right? That's important. It's smaller. Compare this, right? It's darker. It has no central pallor, right? Smaller, darker, no central pallor is classical spherocyte. The moment you see spherocyte, I should always think of the most common cause. Can anyone tell me what's the most common cause of spherocytes? It is not hereditary spherocytosis. Hereditary is never the most common. The most common is by default your AIHA. The most common cause is autoimmune hemolytic anemia, which is an acquired disease. Okay, it's an acquired disease. It's an autoimmune hemolytic anemia. The reason it's the most common, that's why I have to rule out that first. So whenever you see a case of spherocytic anemia or spherocytosis in any person, the next step to do, you guys know, because I have to rule out the most common cause, right? The most common cause is autoimmune hemolytic anemia. To rule that out, I need to first do a 𝐒𝐿𝐶 test. If 𝐒𝐿𝐶 is negative, if 𝐒𝐿𝐶 is positive, diagnosis sorted. It's autoimmune hemolytic anemia. If 𝐒𝐿𝐶 is negative, then I might think of a hereditary spherocytosis. Fine. This is the general way we have to perceive, right? And when will you suspect hereditary spherocytosis? From a history. See, it's an entrance exam. Generally, they might not ask the most common things, right? So I'm giving you a twisted history. Last NEET exam or last FMG exam had this question. A twisted history to focus towards hereditary spherocytosis. What will, from history, what will you think? It's a hereditary spherocytosis. What? Autosomal dominant is straightforward, na Dharmesh? They might not give you autosomal dominant. Yes, it is autosomal dominant. I'm not denying that at all. It is an autosomal dominant inheritance, by default true. Family history, that is important, right? So if there's a family history, think of hereditary spherocytosis. Please don't go with age alone. Young age is not equal to hereditary. Autosomal dominant disorder generally presents during adult life only. It's not age, it's the family history. 5-year-old can be autoimmune hemolytic anemia, not hereditary spherocytosis. If the family history present, it's hereditary spherocytosis. And generally there'll be triad, like Dharmesh said, I can have an adult with a splenomegaly with a gallstone. Pigmented gallstones, to be very, very specific. Hai na? So if you have pigmented gallstones, adult with splenomegaly, think of hereditary spherocytosis, right? Because to have gallstones, it should be a chronic anemia. Autoimmune is picked up, diagnosed, treated. It's not very chronic anemia, right? Perfect. Think of that, right? Now, if I say a question says, okay, it's proven case of there's a family history, spherocytosis there in microscopy. What is the investigation of choice? Investigation of choice for hereditary spherocytosis, not spherocytic anemia. Proven family history, microscopy there's spherocytes. What do we do? It is EMA flow cytometry. No osmotic fragility test. Osmotic fragility test is not a pretty useful test, right? It's not a pretty useful test. It's kind of wasted. The only place I can use is incubated osmotic fragility test in patients with incomplete penetrance, right? Diagnostic or investigation choices, EMA flow cytometry. We do have osmotic fragility test. Only one use case for me is incubated osmotic fragility test is useful to pick up patients with autosomal dominant case with incomplete penetrance. In those cases, yes, I might think of an incubated osmotic fragility test. Otherwise, there's no use case, right? Most of them are autosomal dominant. But there's a possibility, since it's INICET, we'll have to cover this as well. Autosomal recessive inheritance of spherocytosis. They generally have spectrin mutation and they are severe. Anything recessive, 2 mutations has to be severe. Do remember that. Fine. This is for spherocytosis. Fine. What is this guy? Who's this guy? Classical finding. We'll quickly recap every important keyword with an image. You tell me whatever you remember about this guy. First, a classical finding looks like a bite. It's bite cell. If you think of bite cell, what all comes to your mind? Heinz bodies, bite cells, G6PD, X-linked, boys, stress. Perfect. Everything what is required, Chaitanya has covered. That's all required. Na? There's a classical patient with a bite cell. Chaitanya and others, can anyone tell me what's the other name of bite cell? Like target cells, we call it codocytes. Hai na? A sickle cell, you can call it drepanocytes. What is the other name? It should be episodic hemolysis. The episodes will be after a stress event or a trigger event. The trigger event most commonly is infections in the same order, drugs, right? Then lastly, yes, fava beans. I'm not denying, I'm not ignoring that. Lastly, fava beans. Fine. In drug, primaquine is important, like what Dharmesh said, and your dapsone is an important thing, right? Perfect. Degmaside. Because since everyone knows what is a bite cell, I might use a different terminology. Fine. Okay. Stress, trigger, episodes, very important. After the episode, you will have hematuria because it's both intravascular extra, but in a stressful episode, you'll have intravascular hemolysis. In a microscopy, you will have definitely the classical bite cell, and the other one is your Heinz body. But to appreciate Heinz body, you need a new methylene blue stain. It's not seen in normal stain. Fine. Okay. Investigation of choice. Anyone? You covered almost everything required. Yes, it's an X-linked recessive inheritance. So please look in more in the favor of males being involved compared to females. It is the enzyme analysis. we have to analyze the enzyme. If the enzyme is less, deficiency. Enzyme is more, not deficiency. That's all, right? As simple as that. Can come in exam. Degma says, remember, again, since I know everything, the only way for me to make a question difficult is change the name. Okay, perfect. Next one. What all you know about this guy? Whatever comes to your mind. The same way you Chaitanya answered for Bicels, the important keywords. The important keywords. Chaitanya, see, G6PD can be both intra and extravascular, theoretically speaking. But during a trigger, when the amount of reactive oxygen species is more, it is more intravascular. PNH is obviously intravascular, right? I cannot say only this. See, when I take autoimmune hemolytic anemia, if it is malaria, it changes. Sometimes based on etiology, there's a little bit of change in intra-extravascular, but with respect to inherited conditions, most of them are extravascular. Okay, this is nothing but your sickle cell. Na? This is the easiest one what we know. Sickle cell, or the other name is drepanocytes. Okay, autosomal recessive inheritance. The most important thing, please remember, sickle does not present as hemolytic anemia. This is very, very important, especially the homozygous patient of sickle. Yes, hemolytic anemia is there, but homozygous as well as heterozygous might present with sickle cell painful vaso-occlusive crisis. If there is recurrent, unexplained painful crisis, that's the first way they'll present. Unexplained abdomen pain, repeated, unexplained bone pain, unexplained painful crisis. That's the presentation. Yes, anemia will be there by default. I'm not denying that. They'll be there. But recurrent painful crisis is important. You have to remember that, right? Heterozygous, they might not present at all. Might be subtle. That's your carrier state. But they also might have painful vaso-occlusive crisis. On and off, they might have crisis. Sickle is a painful disease more than being a hemolytic anemia. Fine. So obviously, when you look at a microscopy, you will see sickled RBCs, easily picked up sickled RBCs. If it's a trait, sickled RBCs might not be seen, right? If it's a trait, I may not see a sickled RBCs. In that case, there's a test done called a sickling test. Anyone, do you remember sickling test? Sickling test is done to make sure the RBCs are forced to become sickle. Can anyone tell me what's a chemical used in sickling test? We use a chemical. We add the chemical to a drop of blood. The moment you add the chemical to a drop of blood, it will suck out all the oxygen and it will force the RBCs, if they are abnormal, to become sickle. We add sodium metabisulfate, right? So to a drop of blood, we add sodium metabisulfate. So once you add sodium metabisulfate, this will make it deoxygenated. It will remove oxygen. The moment it removes oxygen, it becomes a bit more stressful for sickle and it becomes that, right? Sodium metabisulfate, fine. And that's a sickling test has been done, right? So if it's an homozygous, easy to pick up sickle cell RBC, right? So investigation of choice, better one is always HPLC, but electrophoresis also is a good enough guide to pick up sickled RBC, right? Electrophoresis or HPLC. How do you confirm it is homozygous sickle? That is sickle cell anemia. Was a sickle cell trait? Is there any important thing to look for? In both these investigation, if there is very high HbF, remember this is a parameter. This is for severe anemia. This holds true even for your beta thal major. Very severe, hemoglobin F keeps on increasing. It's a compensatory increase. Beta thal major mein, there will be more hemoglobin F. Sickle cell anemia mein, there will be more hemoglobin F. Trait may not be there, right? And one more thing is, if it's HbAs, it is trait, both A and S. If it's HbSS, obviously it is an homozygous sickle cell anemia. Fine, it's an homozygous sickle cell anemia, right? Do remember this, fine? And one more thing which is asked, very old MCQ, you have to remember this. Sickle cell retinopathy is more common in which condition? It's more common whenever HbC and S unites. It's HbSC or HbCS, whatever it is one chain of hemoglobin is having sickle, the other chain of hemoglobin is having C, HbC. That's where sickle cell retinopathy is very common. Chaitanya said that in sixth position, glutamate becomes valine, right? Right? Glutamic acid or glutamate replaced by valine. The same sixth position, I'm not going into the controversy of sixth or seventh, since the until undergraduate textbook changes, we're not going into it. If the same glutamic acid or glutamate becomes valine, we use the term HbS. The same glutamic acid becomes lysine, we use the term HbC. It's same place, same beta chain. The only thing is change in amino acid. Okay, fine. Now let's go to the next guy. Diagnosis and what do you see here? And tell me anything what you know about this cell. Simple guy. Target cells, podocytes. Nothing much to remember in this. You already know this. Podocytes in your electron microscopy looks like a hat. An extra information. Codo is hat. Since it looks like a hat in electron microscopy, we call it podocytes. But in light microscopy, I look from the top, it looks like a circle, looks like a bullseye, right? So podocytes, the first thing for me I think of is thalassemia. Fine. In thalassemia, beta is definitely much more common than your alpha thalassemia. Yes, Inshan, Nizar, we'll be seeing that also in very severe case of iron deficiency anemia, right? So, how do you pick up beta thal major? Differentiate it from beta thal minor or beta thal trait. I'm talking about beta, we'll look at alpha soon. Major history. Anemia at a very young age, more than 6 months. Fine. A classical hemolytic phases. The chipmunk phase is what you know. The prominent frontal bone, prominent zygomatic, prominent malar bone and everything, right? And very, very important, this is transfusion dependent. The kids cannot survive without blood transfusion. That tells it is major, right? Minor, it's incidental diagnosis. It's almost similar to IDA. Clinically, it is similar to IDA. Just weakness, pallor, that's all. It will not have any specific or classical finding clinically. Just an incidental diagnosis for anemia, right? Sorry. Okay. Yeah. Fine. Yes, X-rays will have hair on and splicing mutations required, but we will go for the easy way to diagnose, right? Then a smear. How do you differentiate in a smear? Just in a peripheral smear, no HPLC, nothing. In a peripheral smear, I look for this. If you see target cells and one more important finding, that is NRBCs, nucleated RBCs. If you see nucleated RBCs, it's a severe hemolytic anemia. Obviously, this is microcytic hypochromic, no doubt in that. Here, I'll see only target cells, no NRBCs, and it also is microcytic hypochromic. Fine. The way to differentiate thalassemia from your iron deficiency anemia, thal minor to iron deficiency anemia, we'll look at it later, right? The last one is, this also is diagnosed based on HPLC or your hemoglobin electrophoresis. Fine. HbA2 being elevated is an important clue here. I am not looking into other findings, I am looking into one important finding. HbF being extremely elevated is a very important clue for thal major. F for major, A2 for minor, right? Please remember, these are easy ways for us to differentiate. Other findings, you said hair on end appearance, that can be seen, right? Crooked appearance can be seen. Multiple other findings can be seen by default, fine? Okay. Now, if it's an alpha thalassemia, this came in an exam, I'm sure you know, the investigation of choice for every alpha thalassemia, if you have to diagnose 1, 2, there are 4 different types, no? It's always globin gene study. Because HPLC cannot diagnose everything. It can diagnose 3 of them, not all 4 of them. It's a bit difficult. Sometimes 2 only can be diagnosed easily. 3 might require, a third might require a bit of modification of HPLC, right? Globin gene study is the investigation choice for alpha thal in general. For beta thal, HPLC is better. If HPLC is not there, hemolytic is not there, genetic study is there, I'll prefer genetic study, fine? Okay. Now, let's go to differentiation based on your microcytic and hypochromic and macrocytic and hypochromic, right? I have changed this. I is important, right? Microcytic, you know that the mnemonic is Sitama. I don't want you to remember Sitama because I want you to remember iron deficiency first, thalassemia second. Rest everything is not even required for me. A is anemia of chronic disease. It's not a microcytic anemia, it's an normocytic anemia, right? Then sideroblastic if required. Okay, it's not Sitama. You don't, if you think of sideroblastic first with a mnemonic in real life, you're screwed. Lead poisoning, yes, it will come under sideroblastic to some extent, right? Okay, normocytic. Two guys, never forget, anemia of chronic disease, right? AOCD, and anemia in CKD. Two classical places where do you see normocytic anemia. Okay, how do you treat anemia of chronic disease? Last time in the INICET, a question came like, how do you treat anemia in CKD? Simple, don't think too much. Erythropoietin. CKD, this kidney is failing, not producing erythropoietin. How do you treat anemia of chronic disease? Treat the chronic disease. If TB is causing it, treat TB. If rheumatoid is causing it, treat rheumatoid. This will automatically come back to normal, right? Because these are both secondary problems, not primary problems. So take care of the primary problem, it will automatically come back to normal, right? Then macrocytic, megaloblastic is different. It's your B12 and folate dependent deficiencies. And then we have classical macrocytic. In classical macrocytic, where you won't have the bone marrow findings or megaloblast will not be there, you go for liver failure, you go for alcoholism, go for hypothyroidism. Few common things which will cause macrocytic anemias. Fine. Alcohol, liver failure, and hypothyroidism. Okay. Perfect. So we know a little bit about the difference of anemia based on the MCV. Fine. When do you call it macrocytic? The number of MCV less than MCV less than MCV less than. When do you call it macrocytic? Less than 80, 80 to 100, greater than 100, right? These are places when you call it microcytic, normocytic, and macrocytic. Okay, there's a few common things required to differentiate between micro, macro, and normocytic anemias. Fine. Okay, let's go to iron profile. So this is important. There have been multiple questions just based on iron profile, both in INICET, NEET PG as well as in FMG, right? But these are the common iron profiles. I'm not going for protoporphyrin, which is not being done regularly. Commonly, every patient who's suspected iron deficiency anemia will have this iron profile, right? Serum iron, transferrin saturation. Never forget this. These both are directly proportional. Ferritin, TIBC. These both are indirectly proportional. Matlab, if iron is reduced, saturation will always be reduced irrespective of the disease. If ferritin is reduced, TIBC will be increased irrespective of the disease, and vice versa. Fine. So now let's take two common diseases, IDA and anemia of chronic disease. These are two common diseases where always you have a confusion, right? IDA, what will happen to iron? I want you guys to comment so that you need not revise again, right? What will happen to iron levels in iron deficiency anemia? Less, more? Not difficult, na? Less. So if that is less, saturation directly proportional, less. What will happen to ferritin in IDA? Ferritin is the most sensitive test for IDA. It's the most sensitive, the first one to change and everything. That also will be less. If it's less, what will happen to TABC? Will be more. Directly inversely, that's more than enough for me to evaluate them, right? Next, anemia of chronic disease. Chronic disease, put a star here. I'm going to start with this. Okay? Chronic disease, ferritin will be more. The reason ferritin will be more in anemia of chronic diseases, it's an inflammatory marker. In COVID times, we did ferritin. It's an anemia, it's a marker of inflammation. Chronic disease is chronic inflammation, more. If ferritin is more, TIBC is less. If stored form of ferritin, that's iron, is more, the free form is less. It's related. So if it is less, this also is less. Okay? Very easy way to remember. The only thing is start anemia of chronic disease with this part. If you start from some other part, it will get screwed. You have to start with ferritin because if you want, write this also next to it. It's an inflammation marker, and in any disease with chronic inflammation, it will become more. That's all. It's an inflammatory marker. That's it. Very simple, right? Okay. One more thing, I need to differentiate your iron deficiency anemia versus Thal minor. Okay. Yes, your podocytes or target cells will give me a clue, but there are two CBC findings, machine related findings. You know that Menster's index and your RDW, right? Since we are in the fag end of revision, I'm not going to the hardcore concepts of this, but I'm sure you will remember this. Thalassemia, something which has been making grounds. RDW will be narrow or lesser or normal, and your Menster's index will be less than 13, right? So that is thalassemia. Fine, less, but there is real explanation for it. We have discussed that in the regular lectures. I'm sure you know that, right? RDW will be wider in case of your iron deficiency anemia, and your Menster's index will be more than 13 in case of an iron deficiency anemia. Fine. Okay. Classical finding. What is finding? Anyone? Everyone will know this finding, right? What's this finding? What do you think this is? That's a classical case of an hypersegmented neutrophil, right? There's a classical case of an hypersegmented neutrophil. You think of an megaloblastic anemia by default, right? It's a classical hypersegmented neutrophil. You'll easily pick up hypersegmented neutrophil more than 5 lobes or more than 6 lobes. We call it hypersegmented megaloblastic, right? So again, the difference is B12 folate. Two important thing, one history wise, one simple investigation wise, right? History of B12 vegan diet, and here history of lack of fruits and greens, because folate is a heat labile vitamin. So even meat has good amount of folate. We cook and eat meat, right? That's the problem. And you will have neurological symptom. Subacute combined degeneration of spinal cord is a classical finding. Here, no neurological symptom. Okay, these are few things which helps me to easily differentiate it's B12 or folate deficiency, right? Ames old repeat, do remember this, never forget this. If there's a B12 deficiency, the reason or the way to treat them is use only B12, because if you use both folate and B12, if by mistake we use both B12 and folate, this worsens neurological symptom. Remember this. So old repeat of Ames, because of abnormal redistribution, it will worsen neurological symptom. So you'll use only B12 treatment for a B12 deficiency, and folate may preferably only folate. If required, give B12 and folate. Doesn't matter that, right? Okay. Next one. There's a bone marrow biopsy. Anyone? Spotter diagnosis. Spotter and diagnosis. That's nothing but this is the bone, this is the bone, this is the bone, this is the bone. Between the bone, what we have is clear areas, empty areas. That is nothing but fat. If there's fat in the bone marrow biopsy, we call it not working aplastic marrow, which is an aplastic anemia. Fine. It's aplastic anemia. You will see fat in a bone marrow biopsy. Same in aplastic anemia. What will be the finding in a bone marrow aspirate? That's an important MCQ. Bone marrow aspirate will have dry tap. There'll be nothing there. There'll be a dry tap. In myelofibrosis, we'll have dry tap. Even in a bone marrow aplastic anemia, we'll have a dry tap, right? If you see bone marrow cellularity in any person less than 25%, suspect aplastic anemia. This is an important clue for you to remember. There are two more findings which might help you in diagnosing aplastic anemia. One, reticulocyte count will be reduced. There are very rare instances we'll have reticulocytopenia reduced. Reticulocytosis, hemolytic anemia. less, bone marrow is not performing well, right? Reticulocytopenia is very important clue. And the most important thing, splenomegaly should not be present. It should be absent. This is especially useful when you diagnose in real life. If spleen is palpable, it is not aplastic anemia. It should be absent in case of an aplastic anemia. Fine, remember this always, right? So these are few quick revision points with respect to RBC disorders, right? Let's go to our WBC. I'm going to talk about clue points because these are most of the lymphoma leukemia is going to come as scenario-based question or with more stress on the CD markers, something of that sort, right? Scenario-based question is something which will help us to easily click up. Okay, I am having a patient with DIC and leukemia in the options. I'll think of AML-M3 because AML-M3 presents with DIC. Those important clue points, right? ALL. The first clue of ALL is a child. Child leukemia ALL. What do you think of child and a lymphoma? What do you think will be the diagnosis? Anyone? Child leukemia ALL. What do you think of child and lymphoma? Child and lymphoma. Child and lymphoma, always think of Burkitt's, right? Children and hematological malignancies are very, very specific. Child with a history and options are lymphoma. The first and the foremost possibility is only Burkitt's lymphoma. A young child, swelling. I don't even want mandible swelling. Child lymphoma is Burkitt. Child leukemia is, you see, ALL. Very, very unlikely to have others. At least for undergraduate, it's very unlikely to have others. Child is the first important finding, right? Child plus lymphadenopathy. Generalized lymphadenopathy is what I mean by lymphadenopathy. Second thing, child plus mediastinal widening. In the X-ray, I have mediastinal widening. This is BALL. B type of acute lymphoid leukemia. This is classical for TALL. T for thymus dependent, right? TALL, right? Yadav, NHL is a very broad category. You have to be very specific on what type of NHL it is, right? So Burkitt is a very good answer for child plus lymphoma, not every NHL, fine? Okay. AML-M3, again important clue points. A leukemia with presence with DIC. There's no other leukemia with presence with DIC. Classical findings of DIC, I think of an AML-M3. Obviously, you have the named cells also. You know that there are Faggot cells. There are your bundles of OR rods. You have buttock-shaped nuclei. Those are also classical clues. But AML, leukemia with DIC is undoubtedly your AML-M3. AML-M4 and M5, we have chloroma. Chloroma is extra medullary blast. It goes outside the medulla. Medulla is your bone marrow, right? For which one? Hodgkin's? See, Hodgkin's is not a lymphoma seen in children. I can have them in adolescents or like 20 to 30 years of age. Is that the question, Nizar? So if when I say extramedullary blast, its meaning is a question with having gum hypertrophy or gum hyperplasia. A question with skin lesions. A question with proptosis. And the options are leukemia. I'll think of AML-M4 or AML-M5. Because very rarely others goes to the skin because most of them stay inside the bone marrow only or in the blood circulation. Not gum bleeding. Please read the question carefully. Gum hypertrophy, gum hyperplasia, I'll think of M4, M5. Gum bleeding is a symptom of every leukemia because of thrombocytopenia, right? Please remember, it's gum hypertrophy or gum hyperplasia, not gum bleeding. Okay? It's gum bleeding is different, hyperplasia, hypertrophy is different. Think of AML, M4, M5, fine? AML, M7, child with Down syndrome. Both the clues. If you're going to have Down syndrome, yes, then a child has a very high risk of AML, M7. Otherwise, not much risk of AML, M7. Child with Down syndrome, important for us to remember that, fine? Okay? And there are few key translocation, which is exception to the criteria, not crisis, of AML. When do you call it acute leukemia? Very basic question. What should be the amount of blast to call it an acute leukemia? Okay, I didn't see so many blasts to call it an acute leukemia. 20%, right? We need more than or equal to 20% blasts in bone marrow or in peripheral smear to call it an acute leukemia, both for acute lymphoid, both for acute myeloid. Minimum 20% blast should be there, right? But there are exceptions to this criteria. If you see translocation 814, you see translocation 1517, you see inversion 16. These are the exceptions. I can use it. I can still call it an AML even with 10% blast. Not 25, it's 20%. Fine. Even if it's 10% blast, if I have any one of this, not all three, any one of these translocation, I can definitely call it an acute myeloid leukemia. For acute lymphoid, I don't have an exception. It's anything should be more than or equal to 20% minimum to call it acute lymphoid leukemia. Fine. These are a few exceptions. You should remember them. Any one of these. Okay. Let's go to images. Just a random image is given. The first question is, how will you call it a blast? If the question says, blasts are increased and the image is given, you could be able to say it's a blast. If it's a random image, how do you know it's a lymphocyte or a blast? How do you know it's a myelocyte or a blast? The most important clue is the size. To call it a blast, remember this is common for both ALL and AML. It should be at least more than 2 times size of RBC. See, RBC is always there for comparison. Or the other is for myeloblast, right? That is the next specific place. If I have only a slide, I need to call it a blast. To call it leukemia or not, size. Easily more than 2 times. More than 2 times. It's an RBC, more than 2 times. More than 2 times size of RBC is a blast. Then, yes, you have a very dark chromatin. A dark blue chromatin. There are no granules, no OR rods in one side. Here I have OR rods or granules present. Fine. These are your OR rods, right? You can see a rod-like structure. What is the right-hand side image? OR rods present, granules present, blast more than 2 times the size of RBC. This is myelo or lympho? Classical, na? This is a classical myeloblast. Both absent, but still I am seeing blast. They are lymphoblast. Very simple. This is the first line of division. Then obviously comes your images, your markers. I might do PAS, I might do MPO, I may do CD markers. Say has exactly lymphoblast, exactly myeloblast. But first microscope में size and the presence of OR rods, presence of granules or not, right? Then obviously markers. PAS na has multiple applications with respect to leukemia based on the pattern of staining. A dot-like pattern, okay, or we call it a block positivity. A block positivity or dot-like pattern is diagnostic of lymphoblast. Please remember, PAS can also be positive in myeloblast, not just lymphoblast, also in myeloblast. A cytoplasmic blush-like positivity. Entire cytoplasm is positive. It's classical for AML M6, the erythroleukemia. It's not dot-like. It's also positive in myeloid leukemia, but please look at that type of positivity. MPO SBB. MPO is much superior and specific than SBB. SBB is a very non-specific stain. Fine. If there is a lymphoid blast, exceptions. See, exceptions are always MCQs. A lymphoid blast, you guys have to answer this question, listen carefully, which is negative for PAS, but positive for SBB. Right? There's a myeloid marker, na? SBB and MPO are myeloid marker or myeloid blast marker. Tell me which lymphoid blast will be positive for PAS, negative for PAS and positive for SBB, which is the ulta. Normal lymphoid blast will be positive for PAS and negative for SBB, right? So this is your L3 blast. L3 blast was the older name for Burkitt's blast. Burkitt's lymphoma going into the bone marrow and forming a blast, we call it an L3 blast or a Burkitt's blast, which is very unique. It's a lymphoma blast, negative for PAS, positive for SBB. Fine? Do remember that, right? And you have so few CT markers to remember. See, these are facts. the way a question will be asked is, all of these will be compiled in the form of a question and asked, right? 3 is T cell marker, 20 is B cell marker, where do you see 14 and 17? This is monocytes marker. 13, 24, it's myeloid marker. 60, 41, 61. 41, 61, na, it's actually glycoprotein 1B9, 2B3A, those glycoproteins. So which leukemia do you think will have that? We see glycoprotein 1B9, 2B3 in megakaryocyte. Huh? It's a megakaryocytic leukemia which is positive in AML M7. This is positive in M4 and M5, right? I have not given a marker for AML M6. You will tell me the marker for AML M6. Can anyone at least think of one marker for AML M6? It's a erythroid leukemia, na? So at least one marker for AML M6. Any one marker which comes to your mind. No, apart from, I'm asking about any other marker for other than PAS. AML M6. See, if you're stuck at any new thing, na, look at the options and see what will relate. It's hemoglobin A. It's erythroid leukemia, has to be positive for hemoglobin A. Or there's one more marker called as glycophorin, because it's a normal molecule seen in every RBC, right? The moment you have markers present in an RBC, obviously it'll be positive in erythroid leukemia. As simple as that. Just a hemoglobin A, glycophorin A, positive for RBCs, positive for erythroid leukemias also. Fine. Perfect. Okay. Next image. Can anyone tell me what comes to mind when you see this image? We'll go stepwise. Leukopenia, leukocytosis. More WBC, less WBC. Definitely more WBC, na? Obviously. The WBC what you're seeing is predominantly blast, or you're seeing multiple types of cells, like a neutrophil, like a eosinophil, like a band form, like a myelocyte, like a blast, multiple. Obviously, you know the answer now, na? Right? Now, the classical symptom is elderly person, 50 plus, with massive splenomegaly. Okay? If this is the history, next step will tell me the diagnosis. But for that, this history is seen in two conditions. The same exact history is seen in two conditions. Elderly person, massive splenomegaly. One is the image what we see here, CML. Classical, na? Chronic myeloid leukemia. Right? The other is hairy cell leukemia. Right? A classical elderly person with massive splenomegaly. Both will have the same. In CML, you have leukocytosis. Here you have pancytopenia. See, both history are same, but the leukocytosis and pancytopenia is exactly opposite, right? So sometimes you have to look a little bit more in detail before jumping into massive splenomegaly, it has to be CML. Diagnosis will be entirely different, just with one more finding, right? Please be very careful on this. These findings are very important for us to rule out things, right? And obviously in leukocytosis, you have the shift to left, classical. Or obviously you'll have here hairy cells. Now hairy cells is positive for a marker called as TRAP. TRAP positive hairy cell, diagnostic of hairy cell leukemia. Here shift to left will be there. You have the funny name. I hate the funny name. The college girl appearance or the garden party appearance, right? The convent girl is for CLL, but it's bit varied amount of cells. Like a party where they have colored dresses, everyone will be dressed different. So like this, the cells will be in different amounts. So we call it a shift to left or in garden party appearance or a college girl appearance, right? Okay. Investigation of choice here is either PCR, FISH is obviously better than karyotyping. I have to prove it, right? CML does not require a flow cytometry. CML will require a FISH genetic test to prove the Philadelphia translocation. Fine. Okay. Diagnosis, spotter. You guys know the answer. Spotter. What do you think is the answer? It's a classical spot. No, you see a classical smudge cell. Whenever you see smudge cell, it is diagnostic of your CLL, right? Smudge cell is diagnostic of CLL. Elderly lymphadenopathy. Again, whenever I say lymphadenopathy, it is generalized lymphadenopathy plus history of autoimmune hemolytic anemia, very classical for CLL. Even along with that ITP, again very classical for CLL. And in microscopy in CBC, you will have lymphocytosis. Lymphocyte count will be more, along with the classical finding of smudge cells. The moment you see smudge cells, it's diagnostic of CLL, right? Hepatosplenomegaly might not be seen in CLL. It's a lymphadenopathy, primarily a lymphadenopathy relation, right? So these are smudge cells, basket cells, however you want to call. The reason for smudge cell, this was asked in an INICET AIMS exam. It's loss of vimentin. Vimentin is a cytoskeletal protein. Because of the loss of vimentin, the cells become very fragile and it smuts. It breaks down. That's classical reason for smudge cells, right? If you have to go to CD markers, see, I'm going to talk about the specific marker. I'm not going to say that, okay, CD 1920 positive. It's a B cell tumor, has to be 1920 positive. There's no question about that, right? So if a question says you have CD5 positive, CD23 positive, it is CLL. Along with smudge cells, 5 positive, 23 positive. In flow cytometry, this is a flow specific marker, CD200. It's only in flow, not in a biopsy, not in the bone marrow aspirate. Only in flow I can use CD200. That's also positive for CLL. Fine. Okay. Next guy. Diagnosis. Diagnosis. Multiple follicles. Na? Has to be follicular lymphoma. Classical clues. Elderly. Very, very, very slow growing tumor. That's the clue here. If you have a history of lymphadenopathy present for 5-6 years, slowly growing follicular lymphoma, right? That's very, very classical. Translocation 14-18, chromosome 18 may have BCL2, the anti-apoptotic gene. The cells don't die. That's the reason it's very, very slow growing, right? Microscope may you will see recurrent follicles will be there. That's diagnostic, right? Increased both in cortex and medulla. The lymph nodes, cortex and medulla. That's diagnostic of follicular lymphoma. IHC. In most of the IHC, na, always go to the history. Always go to the genetics or the pathogenesis. If it's BCL2 positive tumor, I know I'm talking with follicular lymphoma. Nizar, follicular hyperplasia is a reactive condition, lymphoma is a malignant condition. That's the only difference. And yes, there are few difference in microscopy and IHC to differentiate. If it's a lymphoma, I think of follicular lymphoma. Fine. Okay. Spotter. What do you think the answer is? You know the answer. What is this? The spotter. Diagnosis. That is Burkitt's now. It's your classical starry sky appearance. Starry sky cannot be mistaken, right? I always say it's Burk 8. This is my senior's way of remembering things. It's Burk 8 lymphoma because translocation 814 or translocation 28 or translocation 822, right? It's Burkitt's lymphoma, so that we also remember the genetics with that, right? Starry sky appearance, Burkitt's lymphoma, that's all, right? And here, like we discussed before, Ki67 is 100%. Burkitt's lymphoma has both endemics and sporadic. Both endemic and sporadic, both of them will be EBV positive. Endemic is 100%, sporadic is also decent enough. It's EBV positive only, right? Burkitt's lymphoma, one of the important problem or prognostic indicator of Burkitt's lymphoma is the early diagnosis, right? So they might have tumor lysis syndrome on chemotherapy. That's one of the important thing. You have to look into it. Make sure that you will not give the chemotherapy without thinking of maintaining the ionic balance. Otherwise, chemotherapy, tumor will die. We'll lose the patient also. Tumor lysis syndrome is one of the important thing to keep in mind for Burkitt's lymphoma. Burkitt's lymphoma can go into bone marrow, can spread into bone marrow, which creates your Burkitt's blast, or the older name of L3 blast. Burkitt's blast is a very unique appearance. It's a lymphoid blast. You will have the high NC ratio, the big blast and everything. The classical thing is the cytoplasm. The cytoplasm will have a sky blue cytoplasm. Not just that, in that there'll be multiple vacuoles. Okay. We have sky blue cytoplasm with vacuoles in the cytoplasm. So these are classical for Burkitt's blast. Burkitt's blast can be a spotter. If you have tiny vacuoles, bluish cytoplasm, think of a Burkitt's blast. Fine. And this is the lymphoid blast, which I said previously. It will be PAS negative and SBB positive, not MPO, SBB positive, which is unlikely of other lymphoblasts. Fine. Okay. Few more classical spotters. You know the answer. Tell me what this is. What is this finding and where do you see it? What is this finding? Where do you see it? That's a hallmark cell or an embryo-shaped cell seen in case of an ALCL. No, we don't see that, Watson. It's an hallmark cell. It's an embryo-shaped nuclei, hallmark cell. We see in anaplastic large cell lymphoma, translocation 2-5. This translocation was asked in last FMG exam, so do remember them. Okay, it's not a tuberculosis. Yeah, see, Langerhans cell, Dharmesh, it's multinucleated cell. This is a single nucleus which is curved like that, right? We are talking about lymphoma. It's anaplastic large cell lymphoma, right? This is skin biopsy. Okay. In this skin biopsy, again, I'm talking about lymphoma, where I have WBCs going into the epidermis. This is a classical epidermotrophism. Diagnosis? I'm sure you know the diagnosis of epidermotrophism. We always think of a skin-related T-cell lymphoma, mycosis fungoides. Mycosis fungoides is a CD4 positive tumor. You will definitely read them in your dermatology. Mycosis fungoides will have these tiny collections. Now we call it a microabscess. What microabscess? Which amoeba hem? Vicky. That embryo-shaped cell. Huh? CD4 positive cell. And what's the microabscess called as? We call them a Potter's microabscess. That's also a classical finding seen in a mycosis fungoides. Fine. Okay. And what is this? Here, the cell looks like as an indented nuclear membrane. For someone, it looks like a cerebriform appearance. Monroe is for psoriasis. Yes. We have a cerebriform appearance, which is the classical finding for Sézary cell. Sézary cell is like an next step of mycosis fungoides. Systemic mycosis fungoides, systemic T-cell lymphoma, Sézary syndrome, we have Sézary cell. And this has not been asked, but it's a very famous cell, you know, the cloverleaf RBCs, so cloverleaf shaped cell is diagnostic of an adult T-cell leukemia lymphoma. It's by HTLV1 virus, human T-cell lymphotrophic virus, classical thing. Pretty bad prognosis, spreads a lot. Flower shaped cell or a clover leaf shaped WBC, right? These are predominantly T cell lesions. Whatever classical lymphomas we see, they are B cell. These are all T cell lesions, right? Spotter. You must have seen this image multiple times now. I hope the similar image comes in exam so that you won't miss them, right? A classical ulci with pink nucleoli. If the center nucleoli is blue in color, it's an intranuclear inclusion, it's CMV. Pink nucleoli, we have a classical RS cell. The same center is blue color. The blue color inclusion, the outside inclusion, blue color, think of an CMV virus. Okay. Pink color, classical RS cells, right? Classical RS cells, we already know the IHC, we discussed about that, right? In classical RS cell, if it's lymphocyte depleted variant, that's the worst prognosis, and always think it is HIV positive and obviously EBV positive also. In classical RS cell, the most common variant is nodular sclerosis. Nodular sclerosis is EBV negative. Rest everything is EBV positive. Mixed cellularity is positive, lymphocyte rich and lymphocyte depleted, everything is positive, right? This is your popcorn RBC. Sorry, popcorn shaped cells, popcorn shaped RS cells. Popcorn shaped RS cells is a classical finding in an NLPHL NLPG is also EBV negative lesion. We already know the marker profile. The most important thing for me is PAX5. PAX5 is strong here. PAX5 is not weak. PAX5 is weak in every case of classical Hodgkin's lymphoma. Fine. Okay. So that was just a quick outlook of whatever required from an WBC, RBC perspective and hematology perspective, right? Let's quickly move towards systemic pathology. See, systemic pathology, there are a few places which I want to concentrate on. One is the MI table. The postmortem appearance in MI keeps coming repeatedly, the timeline of infarct. Glomerulonephritis, few important findings you have to remember about it. Little bit about ulcerative Crohn's, we'll talk about it. And gastric tumors, we'll talk about it, right? These are few things I feel it's must to know at least these things in the last few leg of revision of INICET, right? Again, like I said in the start itself, systemic pathology is something which will always have a good amount of overlap with medicine, surgery, OPG, whatever you want to talk about, fine? Based on that, you always please integrate, please have both the inputs and make sure both of them fall in the right way before giving an exam, fine? This is postmortem appearance of MI, the postmortem finding in MI. Okay, let's have a quick overlook and we'll complete it so that you'll have a good amount of time before you go for an pediatrics revision, fine? So the first finding, the first light microscopic finding is this. Can anyone tell me what this is? It is seen in half an hour to 4 hours post-MI. There's a first light microscopic finding. Obviously, we see in electron microscope. We don't worry much about that. That's your waviness of fibers. The fibers look wavy. Obviously, you can see this. The fibers of the cardiac muscle. Here, it's completely normal. So obviously this part is wavy. Waviness fibers is a classical finding, the first finding seen in light microscopy post-MI. It is seen between half an hour to 4 hours. After that, 4 hours to 24 hours. In this timeline, you'll have only necrosis. Not even the inflammatory infiltrate will be seen here. You will see only necrosis, which means microscopy you will see predominantly pink anuclear fibers. Pink cardiac fibers without nucleus. There'll be no inflammatory infiltrate also. It will take at least a day for inflammation to come inside because the amount of necrosis here is big. It's not like a healing by primary intention. This healing by secondary intention, tissue loss, right? So between 1 to 3 days. See, Robbins gives first day that neutrophils will start coming inside. Second day they'll be in peak. Third day it will reduce. I cannot say that in the image. If I see like this, these are neutrophils, no? These are dead fibers. All these are the dead cardiac fibers. In between the dead fibers, I see neutrophilic infiltrate, right? That is 1 to 3 days. You will see obviously necrosis. Necrosis will not go anywhere. Plus neutrophils. If you see neutrophils, how do you pick up neutrophils in biopsy? Bent nuclei. Bent blue nuclei. It's like this. Cells with bent blue nuclei. That's your neutrophils, right? So bent blue nuclei, it's neutrophil. If you see that, it's somewhere between 1 to 3 days post-MI. It's not immediate, it's a little bit later. Vicky, you're too early, right? You complete MBBS, then we'll talk about it, right? Things might change a lot. Fine? 4 to 7 days. After neutrophils, who comes inside is your macrophages to clear the neutrophils, right? So macrophage, how do you find? 4 to 7 days predominantly in microscopy allow macrophages. And predominantly in macrophages, you will see clear cells. Because macrophage's other name is foamy macrophage. Hai na? Foam is nothing but clear. If you see lots and lots and lots of clear cells, lots and lots and lots of clear cells, clear nuclei, it's foamy macrophage. Please remember this forever. I can use this concept in surgery also, right? 4 to 7 days, the tissue has nothing, no necrotic tissue, only macrophage. You will see only macrophage here, you won't see even necrosis. This makes the tissue extremely weak. In MI, the risk of myocardial rupture is also more in 4 to 7 days. So like I said, I can use this for any wound healing by secondary intention. If you remember surgery, there's a very important topic called as burst abdomen. Happens around 5 to 8 days. Same timeline. Because in this timeline, I won't have anything, only inflammatory cells. So easy to burst. The wound will easily burst or rupture. Myocardium also will rupture. Surgical scar also has a possibility of dehiscence. Again, around same days, 4 to 7 days or 5 to 8 days. Fine. Now, 7 to 14 days. This varies. Initially, I'll have like 7 to 10 days, I'll have bit of a granulation tissue. After that, slowly scar starts forming, right? But over the bit of 7 to 14 days, what I'll see is you will have granulation tissue. So in granulation tissue, I have two components. One is blood vessels plus collagen. Can anyone comment what type of collagen? What type of collagen we'll see here? Collagen type 3. Initial collagen in granulation tissue will always be collagen type 3, right? Slowly, after, let's say, post 10 days, it will be predominantly more collagen and less of blood vessels. But still, I will be calling them a granulation tissue only. Fine. Slightly, there will be scar formation. Predominantly be type 3. Then it will automatically change to type 1, right? Like Sushma said, initially be type 3. When it becomes a scar tissue, that's post 14 days, even 1 year, 2 year, 3 year, whatever it is. The only thing I'm going to see is a scar. In this scar, I'll see predominantly a classical type 1 collagen. After that, it will keep on remodeling. It will become stronger, weaker based on the situations of wound healing. Fine. Okay. And granulation is the easy way to identify is go for blood vessels. Please don't go for collagen. You will not be able to pick up collagen. Collagen generally is pink in color in light microscopy. For that, I need a stain. The stain for collagen is Mason. There are two Masons, no? Mason Fontana. Where do we see? Melanin. Here we call it Mason's trichrome. 3 colors. Trichrome. In that, blue color is collagen. Blue is collagen. 3 colors, na? Red is generally for muscles. The black is generally for nucleus. Nuclear DNA material, right? It's 3 color. The one thing is important for me is the blue color for collagen. Mason trichrome is a stain used for collagen. Anywhere you have fibrosis, any scar tissue will have collagen and it will be positive for Mason's trichrome. Fine. Okay. So this is a timeline of MI post-mortem. Possibly you might have a question, right? Before half an hour, I won't see anything on a light microscopy. The only finding I can see is electron microscopy. Fine. Okay. Let's go to little bit to your glomerulonephritis. The way to diagnose any glomerulonephritis, not importance on biopsy alone. It should be the symptom, whether it's nephrotic, nephritic, the etiology, then microscopy to correlate, right? So when you see a very thick membrane, see the glomerulus is very thick. You must have seen a normal glomerulus. Now, this is in microscopy, you see a very, very, very thick membrane in the glomerular capillary loop. Plus, clinically, the patient is having a nephrotic syndrome. I'm sure by this time you know what is nephrotic and nephrotic syndrome, right? I need not remind you that, right? Massive selective proteinuria or massive proteinuria, think of nephrotic syndrome. Nephrotic syndrome, thick membrane. To confirm, I do a DIF, which has granular positivity, classical for membranous glomerulonephritis. Fine. Etiology is also important because the recent FDA said that you don't even want biopsy because close to 60-70% of membranous glomerulonephritis is because of antibodies to PLA2R. So if I see anti-PLA2R, I can easily call it membranous glomerulonephritis. This can easily be done by a blood test, which can easily pick up membranous glomerulonephritis, right? You need not have anything. You can easily pick up membranous glomerulonephritis. Fine. Okay. Antibodies to PLA2R. See, there is a possibility that some of the membranous glomerulonephritis can have nephritic syndrome, nephritic presentation also. I am not going for the less 10-15%. We look at the 85%, which is pure nephrotic syndrome only. Fine. Okay. Next. PSGN. This word is what I'm going to look for in microscopy. Endocapillary hypercellularity. More number of cells inside the capillary, like these. These are all endocapillary hypercellularity. I have more cells inside the capillary, right? PSGN, streptococcus. The most important thing is lag time. The history is very, very important. If you have lag time, yes, then think of PSGN. I'm not saying strepto, we'll just use URI. URI or UTI. No lag time, think of IgA nephropathy. You know this, na? Lag time, there's an hematuria. you think of Streptococcus, PSGN or PIGN. No lag time, there's hematuria, you think of IgA nephropathy. That's a classical finding, right? Here, endocapillary hypercellularity, more number of neutrophils into the capillary is diagnostic. So what do I see in DIF? In DIF, you see granular positivity by default for C3 and for IgG also. Because C3 is deposited there, the serum C3 becomes less, will be low. That also is a very classical finding for PSG and PAGN. Low serum C3, right? And how do you treat? Treatment is supportive. Take care of it. It's a short-limited disease. Once the antigen is removed, automatically the kidney will recover. Till that, I have to support the person, right? That's more than enough for us to know this, right? Now, the mesangium is bigger. See, mesangium is a space between the capillaries. Okay, that's mesangial widening. Mesangium can be bigger in quite a few conditions, right? If it's only mesangial widening, I think of two guys, IgA nephropathy, MPGN type 2 or C3 glomerulonephritis. Both will have nephritic range syndrome only, fine. So here, if there is only mesangium is expanded, I don't have anything inside the capillary, fine. Only mesangium widens, fine. So two possibilities for me. I have IgA nephropathy, or we have the older name MPGN type 2, the newer name is C3 glomerulonephritis. So how do I differentiate them? Clinically, I cannot differentiate because both are nephritic. Yes, a history of URI might help me, but not necessarily always, right? Now, I go for DIF. When I go for direct immunofluorescence, both will be mesangial positivity only. It will not be in the capillary. It will not be linear or granular. Both will be mesangial positivity. Here, it will be IgA and C3. Here, only C3. And especially, it will have ring-like deposits. C3 rings. Okay? Ring-like deposit, like round shape like deposit. That's classical for C3 glomerulonephritis, MPGN type 2, right? Or your dense deposit disease. Yes, electron microscopy can also give me a clue, but no one does it. Here, you'll have mesangial deposit in electron microscopy also. Fine. But here, you'll have the classical intramembranous. The only disease which can have that is this intramembranous dense deposit. Fine. It's a classical finding seen in case of one. What is MPGN? Yeah, the membranoproliferative glomerulonephritis or mesangioproliferative glomerulonephritis. Fine. We have MPGN two types, membranoproliferative or mesangiocapillary glomerulonephritis. Fine. Okay. That's for mesangium being expanded. Okay. Now let's go to DIF images. So how do I pick up DIF? We already know that green is positive, right? Here there are two images. I'll write A and B. Just by looking A and B, tell me which is granular. Granular is not throughout, not uniform, and which is linear, which is uniform. Both are glomerulus here. So which is granular, which is linear? A is granular or B is granular? What do you guys think? Everyone comment. A is granular, B is granular. What do you guys think? A is granular, na? So granular positivity is A. That's how it looks. Linear positivity is B. Fine. Please remember, there's only one disease which can be linear. There's no other disease in kidney which can be linear. That disease is Goodpasture syndrome. Only Goodpasture can be linear. No other disease can be linear. It's Goodpasture is for IgG, it will be linear. And Goodpasture, you know the pathogenesis. It is antibodies against collagen 4, right? Alpha 3 domain of collagen 4 or just collagen 4. Goodpasture classically possesses nephritic syndrome. Goodpasture in H&E will have same like membranous, thick membrane. That's all will be there. But it will be linear. The only thing will be linear is Goodpasture syndrome. Granular is rest everything. Your membranous, your SLE, your PSGN, everything will be granular. Based on the history, based on the microscopy, we can differentiate by default. Fine. Next is this guy. What is this guy? Spotter. What is this guy? That's your, like you can see, it's crescent, right? It's like a crescent, a moon-shaped thing growing from the membrane and occupying the Bowman space, right? Crescentic glomerulonephritis or an RPGN. The predominant one which forms the crescent is parietal cells. Parietal cells is the most common constituent of crescent. We do have WBCs, we do have fibrin, we do have your visceral cells also, but the most common constituent is parietal cells. What will be the history of RPGN? Please listen carefully. If, let's say, 2 milligram creatinine today, within 24 hours, the creatinine became 9 milligram percentage. Maximum 48 hours. Generally within a day. Progression is very rapid. That is important. If there's a rapid progression in history with respect to creatinine value, right? I call it RPGN, rapidly progressive glomerulonephritis. Very, very classical. In that, based on immunofluorescence, we change him into 3 types. Type 1 is linear. So what do you think will be the cause? Goodpasture syndrome. Type 2 is granular, which means rest every glomerulonephritis. You can have PSGN, you can have MGN, you can have IgA, MPGN, you can have MGN, you can have IgA, you can have SLE, everything will be here. Fine. Type 3 is also important, primarily for MCQs. It is pauci-immune, which means negative for IF. Type 3 RPGN, you think of vasculitis, vaginous granulomatosis, microscopic polyangiitis. Fine. This is pauci-immune, negative for immunofluorescence in kidney, but yes, they will have a very rapid onset, very rapid progression of glomerulonephritis. Right? It's classical RPGN types. And electron microscopy also came. Why it is very rapid? Simple, because etiology is rapid. The etiologies break in the basement membrane. Iska matlab is capillary ruptured. If capillary ruptured, glomerulus cannot live. Rapid progression, death. That's all. Fine. Okay. Next one, the last but not the least glomerulonephritis is FSGS, where I have entire sclerosis. Focal segmental glomerular sclerosis, right? This is the most common cause of nephrotic syndrome in adults. In adults, the most common cause of nephrotic syndrome is your FSGS. It's a most common microscopic finding in CKD. Whatever may be the cause of CKD, that's the most common. It's an end stage, right? Or is an end stage, any kidney, you will have FSGS only in microscopy. Right? It's a sclerosed glomeruli, that's all. Right? It's a complete sclerosed glomeruli. Because of the sclerosis, the sclerosed glomeruli, you will not have entry of blood. There's no entry of blood. Because of this, automatically, you'll have reduced GFR. Okay? Will be reduced by default. FSGS can be congenital also. The congenital FSGS presents very early in life, right? Few mutations you have to remember. Nephrin, the most common one, the type 1. The podocin mutations, these are the slit diaphragms. The food process proteins, once they are absent, you will end up in having a congenital FSGS, which will also present nephrotic syndrome very early in life. We might mistake for minimal chain disease. Do remember that. Fine. Okay. Now, a little bit about IBD. Right? What all comes under IBD? Anyone? Very simple one, right? What all comes under IBD? It's your ulcerative colitis and Crohn's disease, right? These are 2 basic things which comes under IBD, right? We have ulcerative colitis versus Crohn's disease. The goal is I have to differentiate them. Sushikuma, see, hepatitis B can cause both membranous glomerulonephritis and MPGN. I'm not denying that. So how do I differentiate? One, with help of history. If it's purely nephrotic, I will think generally of an MGN. If it's nephritic, I'll think of an MPGN. Second, I look at the microscopy. It's only membrane thickening, I go for MGN. If it's membrane thickening, duplication of basement membrane, and also you have mesangial expansion, I go for MPGN. Fine. Okay. It's ulcerative versus Crohn's disease. Pathogenesis, right? See, there are few things which you have to remember. It's one of the important cause which has been proposed is hygiene hypothesis. More hygienic you are, my body doesn't know what to destroy. It destroys the commensal, which triggers inflammation against commensals or like an autoimmune condition. GI is the largest place where you have commensal pathogen and the commensal organisms. All of them will be triggered, right? Okay. There are multiple gray areas to say your Crohn's might have few genetic mutations. Does anyone know any one genetic mutation which happens in Crohn's disease? Any one genetic mutation in Crohn's disease? There are few documented genetic mutations. There are few XYZ like which is not very well documented as well. Any one genetic mutation? I'll give you a clue. It's one of the recognition receptors. SMAR. You would know. Anything else? Anything else, Dharmesh? If you're talking about SMAD, it's different. It's seen in your polyps. It's seen in juvenile polyposis syndrome. NOD2 is something which I want you to remember. APC is seen in your adenomatous polyposis coli, right? NOD2 polymorphisms. Do remember. Okay. PTPN22 polymorphism. Do remember, right? NOD2 is your inflammasome, like NOD-like receptors polymorphism. So it's a recognition receptor. Because of that, I have a problem, right? Interleukin receptors. Interleukin 10 receptors. These polymorphisms have been noted in inflammatory bowel disease. Do remember them. And also, the most importantly, ATG. So especially ATG is autophagy related genes. 16L1, it's also related to your Crohn's disease. Right? These are few things which are related. This is primarily to Crohn's disease, which just are a starting point. Maybe in future we'll read them more in depth. Fine. Few classical findings. Crohn's disease will be talked by Sandeep sir in by evening in detail, because GI surgery is something which is bread and butter for surgery, right? So what is the appearance? The classical cobblestone mucosa. Cobblestone mucosa is a classical finding of Crohn's disease because of deep knife-like ulcers. Crohn's disease is transmural knife-like ulcerations. They are very deep. They are transmural. That's the reason you have a very deep knife-like ulcer which looks like a cobblestone. It's been cut completely. Classical Crohn's disease. Fine. Okay. Now, this transmural also gives a second clue. There's a possibility that this patient also will have fissures, fistulas, and sinus, because again it is transmural, going deep and cutting deep, right? Skip lesion is also classical for Crohn's disease, fine. And this, if you see, this is your mesentery and your 𝐒𝐿 joining point. And if you look at this, that mesenteric joint point has moved. That's nothing but fat trapping or your creeping pad of fat. Fine. Creeping pad of fat or fat trapping is a classical finding seen again for Crohn's disease because of the transmural involvement. Classical finding. And it's actually looking like a polyp, which is not a polyp. So we call it a pseudopolyp. Pseudopolyp are nothing but overhanging normal mucosa. They are normal mucosa at the edge of the ulcer. So at the edge of the ulcer, the normal mucosa, this is seen classically in ulcerative colitis. Fine. Because ulcerative colitis will have superficial ulceration. It's not deep, it's not transmural, it's superficial mucosal ulceration. They are completely broad-based ulceration, right? It's completely gone. It's completely gone. So few areas alone is left, which looks like a polyp. Fine. So a few things which you have to remember in ulcerative Crohn's. Microscopy may, if you see granulomas, what do you think of? Crohn's or ulcerative? And there's one more classical finding, a very unique finding, was basal plasmacytosis. Crohn's or ulcerative? And the famous crypt abscess. Crohn's or ulcerative? Granuloma is for Crohn's. Basal plasmacytosis for ulcerative disease. Crypt abscess can be seen in both, but again, predominantly seen in ulcerative colitis than seen in Crohn's disease. Fine. Again, you will read much more in detail in your GIT, the clinical features of how they present. They generally present with an altered bowel habits, mixed with blood and stools. That's a classical finding for both ulcerative and Crohn's and for any inflammatory bowel disease. Fine. Okay. Let's quickly go to gastric tumors. Fine. Just few more minutes. I have gastric tumors left. I have a little bit of genetics, looking at the pedigree left. Banerjee, Ayush, final year, we will have to weigh the possibilities, but definitely I'll ping you soon. Fine. We'll announce something soon for final year. Fine. Okay. Let's compare this. And lastly, I have like 15-20 classical clues for scenario base. I hope that at least one of the 15-20 questions might come in a real exam, right? Okay. Let's look at gastric tumors. So when I say gastric tumors, we broadly classify tumors into epithelial tumors of the stomach, and we have mesenchymal tumors of the stomach, right? In epithelial tumors, I again divide into benign tumor-like conditions where you have Menetrius disease. I am not going into polyps in stomach. Polyps are much more common in intestine. Then obviously I have adenocarcinomas. Fine. Mesenchymal, we have GIST, we have leiomyoma. These are only two important mesenchymal tumor for undergraduate, which happens throughout the entire GIT. Menetrius disease, few important clue words. Protein losing enteropathy. Never forget. No other DD here. If there's a protein losing enteropathy, it has to be Menetrius. Right? In gross, you will have cerebriform appearance. The reason for cerebriform appearance, the rugal folds are very prominent. It looks like a Gyrian sulci of the brain. It looks like cerebriform appearance. It's nothing but prominent rugosities. That's all. The prominent rugae is the cerebriform appearance. Fine. Microscopy, you will have increased in the glands, hyperplasia of the glands, hyperplasia of the mucosa, of the foveolar epithelium especially. And one more important thing is corkscrewing of glands. Corkscrewing glands are classical for Menetrius disease, right? And this is TGF alpha, not beta, TGF alpha mutation, because always is about TGF beta we read in the entire GIT. It's TGF alpha here, fine? Few important clue points for GIST. Adenocarcinoma, we have two important types. One is classical intestinal type, which is the most common. It's a classical adenocarcinoma. Primarily causes chronic H. pylori gastritis, the bad food, the smoked foods, and alcohol and everything, right? Next is your diffuse type of adenocarcinoma. It's not common. It's sort of rare. It's mutation related. CDH1 loss will be there. That's your E cadherin will be lost. Because of that, it has very unique gross and microscopy, right? What is this finding? Everyone knows this, right? Because of the CDH1 loss, the tumor cells grow across the entire stomach and creates desmoplastic response, which gives you Linitis plastica, or looking like a leather bottle, right? It actually looks like a leather bottle or a leather bottle appearance. It's very, very classical, right? And here, this is also classical for diffuse type. Microscopy, you have individual cells. You won't have glands. We call it Signet ring morphology or Signet ring cells. That's classical for diffuse type of adenocarcinoma. Classical intestinal type will have glands, high NC ratio, infiltration. That's looking like a classical adenocarcinoma, right? Okay. Quickly about GIST. GIST we already know. GIST is an abluminal growth. You have 𝐒𝐾𝐝 mutation is the most common mutation in GIST. Fine. In GIST, if you look at the microscopy, you will have spindle-shaped cells with vacuoles. But it's just, we already know the IHC, we read in the table of IHC. CD117 is the most common used IHC because it's 𝐒𝐾𝐝 positivity. And also we know about DOG1, discovered on GIST first. That's a classical IHC, right? Leiomyoma, Whirling, classical, and marker IHC for leiomyoma is SMA. Smooth muscle actin is actin. Smooth muscles is the origin for leiomyoma. Smooth muscle actin should be positive in case of leiomyoma, right? These are just about entire GI tumors which can come. Leiomyoma and GIST can also come in the intestine as well, right? Now, a single table for the polyps. We might get at least one question from polyps because polyps of intestine is something which is important for any exam, right? Again, it might be integrated with surgery or it can be pathology alone, right? We have tubular adenoma, villus adenoma, Peutz-Jeghers polyp, an important one, and a juvenile polyp, fine? We'll go to Peutz-Jeghers and juvenile first. This is Peutz-Jeghers polyp. Please remember, Peutz-Jeghers polyp and Peutz-Jeghers syndrome is different. Polyp is sporadic. Any one of us can get. Syndrome is inherited, right? So Peutz-Jeghers polyp, it's the arborizing polyp where you have muscle going between the glands, right? It's arborizing. It's most commonly seen in jejunum. Microscopy, the best way to identify is you have muscle, the smooth muscle of the intestine, which is there between glands. That looks like the branch of a tree, right? You'll have between glands. That's a classical finding for Peutz-Jeghers polyp. Fine. We call it Peutz-Jeghers syndrome if the mutation, both polyp and syndrome has the same mutation, right? STK11 mutation, if it is inherited. Where obviously you have polyp. In addition to polyp, you have the classical finding of oral pigmentation. Oral mucocutaneous hyperpigmentation is very, very classical. Last NEET PG mein there was a question which most of your seniors missed it. Please remember, Peutz-Jeghers polyp is not only going to increase the risk factor for colonic tumors. Peutz-Jeghers syndrome, in syndrome there will be an increased risk of even breast cancer, most importantly pancreatic cancer. Please don't forget this. Pancreatic cancer has a 50 times increased risk in Peutz-Jeghers syndrome compared to normal population. Yes, colon also, stomach also, but this also is important for us. Fine. Okay. Then this is your juvenile polyp. The important clue for juvenile polyp is age. We generally ignore that, right? Seen in children. Children, rectal polyp, juvenile polyp. Constipation, long-standing constipation is a predisposing factor here. Because of the constipation, the heart feces only, the entire juvenile polyp comes here, right? Okay. See, juvenile polyp, what we see in microscopy, even here what you see is dilated ducts, glands, normal glands, mixture. If you see a mixture of both, dilated glands filled with mucin. You can see that there are multiple tiny particles of mucus which has been there in the glands, right? Dilated glands with mucin is diagnostic of juvenile polyp, right? It's actually why it is dilated mucin. This gives one more name. We also call them a retention polyp. The mucus is getting retained there. So that's why it becomes swollen and looks like a polyp, retention polyp, right? We do have juvenile polyposis syndrome, which is someone said SMAD4, right? SMAD4 gene mutation causes a syndrome, which is juvenile polyposis syndrome, where obviously there's an increased risk of carcinoma and multiple polyps will be seen. Fine. Okay, that's the second guy. The third and the fourth guy is simple. Tubular and villus adenoma, right? The tubular adenoma and villus adenoma, both, only reason differentiate is the risk of cancer formation. Villus, more than 75% villi in microscopy, we call it villus. Less than 25% villi in microscopy, we call it tubular. See, the naming is based on villi only. In between, we call it tubulovillous adenoma, right? Tubular adenoma in microscopy will have tiny glands, tiny tubular glands. The tiny glands are something we call as tubular glands. And they are very, very subtle benign, less risk of cancer, as well as less risk of recurrence. Villus is difficult to handle. Increase risk of cancer as well as recurrence. That's why you have to maybe follow very rigorously. And if at all, if it's becoming bigger and more aggressive, we might have to do an entire colectomy, not just remove the tumor, right? How do you pick up in microscopy? Villi, finger-like projection. And here, tubules. Tiny, tiny tubular glands, tubular adenoma and a villus adenoma, fine? So these are 4 polyps which you have to remember. Tubular adenoma, villus adenoma, Peutz-Jeghers polyp and juvenile polyp, which can come in a GIT, fine? I'm not talking about adenocarcinomas, APC, HNPCC, you must have read it already. You guys already answered about APC and FAP, right? Okay. Just a quick look about amyloid. Two topics in general pathology. One I want to cover is amyloid. Just a quick relook of, I want you guys to be a bit more active here. And about your pedigree analysis, right? Guys, we've been very quiet for some time. Let's fill up this together. Where do you see this amyloid deposits? First, last question. You guys answer, then I'll go to the next one. Where do you see AL deposit? Where do you see AL deposit? And then we have like 10-15 classical scenarios which we'll work on. AL. AL is seen in myeloma. Na? A, anything with chronic inflammatory conditions. Any chronic inflammatory conditions will have A amyloid deposit. A beta 2M, beta 2 microglobin is seen in patients with chronic hemodialysis. Hemodialysis means the beta 2M will not be filtered, slowly keeps on accumulating, has chronic beta 2 amyloidosis, right? ATTR, you see them in senile systemic amyloidosis, which is normal ATTR. If it's a mutated ATTR, there's a condition called as familial amyloidotic polyneuropathies. Fine. Here it is a mutated one. It's familial amyloidotic polyneuropathies. Fine. Perfect. ACAL is, like Dharmesh said, medullary carcinoma thyroid. A beta in the brain, localized, it is Alzheimer's. AIAPP, it's seen in pancreas, again localized. In two conditions, I can see then type 2 diabetes. Please remember, don't write type 1, it's type 2, because only in type 2, zyada insulin production. So you'll have more protein deposition, the C protein, which will be cut and will be deposited. So amyloid deposit, right? Not type 1. Type 1, no insulin production, definitely no extra protein deposition, right? Okay. And also you can see in insulinoma. You have insulinoma. There also you will see your AIAPP. Islet amyloid polypeptidase, AIAPP. Okay, fine. Few just to quickly recap, right? Pedigree, I'm sure if you have followed my lectures, you must know how to solve a pedigree. Pedigrees are very simple to follow. Just I need few rules. The rule 1 of every pedigree, whatever pedigree you see, the rule 1 is this. Rule out mitochondrial inheritance. How will you rule out? Mom affected, how many of the children will be affected if it's mitochondrial? From dad, how many of the children will be affected? Mom, 100%. Maternal, na? Dad, 0%. Mom affected 100%, mitochondrial. Dad affected, no one affected, mitochondrial, right? First, rule out mitochondrial, any pedigree. Once you rule out, I have two simple flowcharts. Two flowcharts now will help us to solve any pedigree which comes to you, right? First, all generation affected. All generation ka matlab, I'll show you a pedigree. First generation, 1% there. Second generation, 1% there. This is third generation, na? 1% there. Fourth generation, 1% there. Fifth generation, 1% there. This is all generation affected. If you have at least 1%, every generation affected is all generation. If the answer to that is no, there's a skipping of generation. One generation is not affected. I'm thinking about recessive disorder. Recessive, only two recessive, na? Autosomal X-linked. If it's only men, which disorder? You already know. We answered in G6PD, na? X-linked. If it's both men and women, okay, both of them are getting affected. Both of them are having the disease. It is autosomal recessive. Simple. All generation affected, no. Recessive. Both men and women autosomal. Only men, X-linked recessive. Simple, na? Next flow chart. All generation affected. Answer is yes. Dominant. Dominant means there are two extra questions. The first question is dad to son. A very, very simple to understand. Assume I'm having an X-linked disorder. If I have to give birth to a son, I should give X chromosome or Y chromosome? I should give Y chromosome. No. Only then it will be a son zygote or a boy baby. If I give X chromosome, the mother also will give X chromosome only because mom does not have Y. It will be a girl baby, right? So I can never transmit my X-linked disease to my son because I have to give Y chromosome to form a son, right? If the answer to dad to son transmission is no, it is X-linked. If the answer to dad to son transmission is yes, it's autosomal. But it's not confirmed with this. I have to ask one more question. The second question is this. All daughters are affected dad. Same example. I have an X-linked dominant disorder. I have to give a girl child. Give birth to a girl child. I have to give only my X chromosome. Hai na? Only when I give X chromosome, the child will be a girl. If I give X chromosome, I am giving the mutated X, which means how many of our daughter zygotes or girl babies I produce, it will by default have the disease, right? So if all daughters or the affected dad are affected, answer is yes. 100% daughter should be affected. Then it's X-linked dominant. Answer is no, goes back to autosomal dominant, right? Little bit extra, one question, right? I'll erase this. All generation affected, answer is yes, dominant disorder. Dad to son present, autosomal dominant. Absent, probably X-linked dominant. Dad affected, all 100% affected, confirm X-linked dominant. No, goes back to autosomal dominant. Clear? Perfect. This, please look at these flow charts and rules the day before the exam. You can solve pedigrees in 5 seconds. I'll show you the pedigrees you're going to solve, right? We have 1, 2, 3, 4 pedigrees. 4 pedigrees more than enough for us to solve, na? Tell me, all generation affected or not? Just answer yes or no in this pedigree. 1, 2, 3, 4, 5. Yes. Yes means I am thinking of a dominant disorder, right? Dominant disorder, next question is dad to son. Look, okay, dad, no son. Dad, no son. So next question is dad to son. Dad to son transmission is no here for me. No means I'm suspecting X-linked dominant. I'll just go back to the pedigree flowchart once again. No means I'm suspecting. I'm not confirming, suspecting. Then I ask one more question. All daughters of dad affected or not? Okay. Dad is affected. Please tell me whether all daughters are affected. Yes or no? No. All daughters are not affected, right? So next is all daughters of the dad are affected or not? The answer to this is no. If the answer is no, my answer is autosomal dominant. Let's go back to the flowchart. All daughters are affected. Answer is no. It goes to autosomal dominant. Only when it's yes, it's X-linked dominant, right? So both the questions are required for me to answer, right? Once you answer that, pedigree can be solved. It's very simple. Let's look at this. All generation affected or not? Answer is no. Because this generation is not affected. Please don't ignore the top one, right? It's not affected here. If the answer is no, by default for me it is recessive. Recessive is very simple. Only men, both men and women. I have both men and women affected, so it has to be autosomal recessive inheritance. Okay? Simple. It's very simple, no? It should be structured, it should be simple. That's conceptual understanding, right? Not to memorize everything, not to have mnemonics. Simple. All generation affected? No. Because again, first generation is not affected here, which means I'm dealing about a recessive disorder. If it's a recessive disorder, next question is only men or both men and women? Only men, na? So I'm dealing with an X-linked recessive disorder. Okay? Perfect, simple. One more pedigree. Pedigrees require 5 seconds. All generation affected or not? No. Right? The first generation is not affected, which means I'm dealing with a recessive disorder. Then both men and women or only men? Both men and women. So you will write, perfect, autosomal recessive disorder. Very happy, na? If you've written this is very important, right? And then say wrong. You have to write, do a mistake to make sure you will never forget it. Why wrong, Yadav? Because I'll go back to the rules. Never skip rules. This is not a traffic signal, right? Rules should never be skipped. The first rule is mitochondrial inheritance. Rule out that always. If I skip the rules, we will make a mistake. Now tell me, mom affected. All kids are affected. Mom affected. All kids are affected. Dad affected. No child affected. Is it mitochondrial? It is mitochondrial. Always any pedigree go for rule number 1. This is mitochondrial. If you skip the first rule, you will end up in having an error. Please remember that. First rule out mitochondrial, then go to flowcharts. If you skip that, it's a mistake. If you don't skip, amazing. 5 seconds only requires pedigree. Fine. Perfect. Done. So you're done. We have compiled and touched base on all the important PYTs of INICET, right? Just few rapid fire. I'm going to have rapid fire questions for clinical scenarios and I want you guys to answer. Whatever comes to your mind, let's see. I have close to 15, 16 questions. Let's see if you can pick up these. Okay. After this, we'll call it a day. Smoker, male, bilateral salivary gland lesion. Diagnosis. I want you guys to answer. What do you think is the diagnosis? Smoker, male, bilateral salivary gland lesion. What do you think? Warthin's, superb. It's Warthin's tumor. These are classical questions that have been asked previously on INICET. I'm just covering them, right? Warthin's will have papillary findings. You have oncocytic pattern with lymphoid tissue there, right? Next question. Admitted patient bleeding from IV line. Patient is admitted in the hospital. There's bleeding from the IV line. Whatever vent flow you put, from that it's bleeding. It's a classical history of DIC. Bleeding from puncture sites. Classical for DIC. If it's DIC, I always look for D-dimer. D-dimer is a specific test which has been asked multiple times. And FDP, na? Fibrin degradation product. It's a sensitive test. Not specific, right? Next, elderly person, massive splenomegaly, leukocytosis. We just discussed that. Right? There's no doubt in that. Shift left will be there, basophilia will be there, translocation 922 will be there. Just one more additional point. In CML, lab score will become 0 or will become low. In case of leukemioid reaction, it will be elevated. Fine? Perfect. Next question. Elderly patient, massive splenomegaly, pancytopenia, monocytopenia. The patient might have hairy cells here, might be trap positive. This also we discussed. That's your hairy cell leukemia. In hairy cell leukemia, the most common mutation is BRAF mutation, BRAF V600E mutation, right? And the most specific marker, TRAP is a good marker, but the specific marker is annexin. Okay, annexin V, annexin A1 is a very, very specific marker here, right? Perfect. Next guy. 2-year-old, prominent frontal bone, failure to thrive, microcytic anemia. Diagnosis. I want specific diagnosis. Not just random group alone, exact diagnosis. 2-year-old, prominent frontal bone, failure to thrive, it's not, kid is not growing appropriate to the age. That's diagnostic of classical of thalassemia major. It cannot be minor. 2-year-old cannot be minor. It should be thal major, right? Perfect. 25-year-old, pain in the digits, priapism. Priapism is painful engorgement of penile structure, right? What do you think is the diagnosis? Very classical. This is what I was talking about. Sickle cell anemia will not present with anemia. It will present with painful crisis. That's a classical presentation of sickle cell anemia. Okay? It will present with, this is nothing but your dactylitis, no? The most common vaso-occlusive crisis is dactylitis. Sickle cell anemia presents like this. Anemia will not be the presenting feature, right? Elderly person, metallic heart valve. What do you see in the smear? Elderly person, metallic heart valve. What do you see in the smear? You see a classical finding called schistiocytes or your broken RBCs or your fragmented RBCs. That's a classical finding which is seen in metallic heart valve. It's also seen in DIC. It's also seen in any place where there's an intravascular thrombus, right? Schistiocytes is a very classical finding. Older question. This was the classical history given last time because metallic heart valve, the RBC goes and hits the valve, breaks. Classical finding for schistiocytes, right? Okay. Early morning, first urine hematuria with pancytopenia. Only first urine hematuria. Rest of the urine has normal. Very classical finding for PNH. Paroxysomal nocturnal hemoglobinuria. Lysis will be only in the night, not in the morning, right? And one more thing, PNH will have pancytopenia with cellular bone marrow. That also is very, very important. Most of the pancytopenia will have hypoplastic bone marrow. Only PNH will have cellular bone marrow. Investigation of choice for PNH is simple. You have to do flow cytometry. Can be done for 55, 59. Or I can do flow cytometry for one more thing called as flare. Flare is also flow cytometry only. Fluorescent aerolization. Flare is better than 55, 59. Fine. Gum hyperplasia with blast in the smear. Specific diagnosis. I always think of AML. M4 or M5 because this is nothing but chloroma. Hyperplasia, hypertrophy, whatever you want to call it, it's chloroma. Fine. Okay. 6-year-old, what's a leukemia you think of? Child, what's a lymphoma you think of? We just now saw this. 6-year-old, I think of ALL. Lymphoma, I think of Burkitt's. Child, leukemia, lymphoma. Child with Down syndrome, I may think of AML M7 also. Right? Keep that in mind. Child, light lesion in skull, microscopy shows eosinophil and coffee bean nuclei. This might relate with the next class discussion, which is pediatrics. A pediatric child, non-secretory otitis externa, painful swelling in the temporal bone, coffee bean nuclei, always suspect Langerhans cell histiocytosis. Always suspect LCH. It's a very classical finding for LCH. Lytic lesion in a child. Same lytic lesion is called elderly. What do you suspect? Here I go with elderly, na? Age changes, lytic lesion, right? It's a punched out lesion in the skull. I think of a myeloma. See, it's the same X-ray finding. History different, age different, diagnosis different. Or could be metastasis. Lytic lesion skull can be myeloma. Mets also can have that. Not often, but myeloma will be the first one, right? Elderly, splenomegaly, pigmented gallstones. Spotter, diagnosis. We saw that. Microscopy will have spherocytes. With a family history, I always will think of hereditary spherocytosis. Right? You always think of hereditary spherocytosis. Okay? Last but not least is an AIMS PYQ. Full house lesion. Full house lesion ka matlab, it will be positive for all the direct immunofluorescence what we do in a kidney biopsy. Positive for IgG, IgM, C3, C1q, everything will be positive. Kappa, lambda, everything will be positive. Right? So it is classical for only one guy, SLE. Every immunofluorescence positive in DIF has to be called as full house effect as classical for NSLE. Fine? Okay. Perfect. That's all for the marathon session for INICET with respect to pathology. We have touch based almost every important PYTs. What I have not covered much is the first, second chapter of general pathology. Questions have been reduced a little bit. Yes, I want you guys to just go and have a look at the RR for the coagulation disorders and bleeding disorders. That also might come definitely in the exam. Fine. Okay. Thank you guys. Hope you guys enjoy the discussion. Go have a tiny little bit of break. I think 2:30 Divya ma'am will come for pediatrics and she'll be covering pediatrics. I hope you enjoy the session and let's see it. Okay. All the best, guys. See you. Bye bye.
Hear me? Quick feedback. Check, 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 check. All right, guys. Good evening, good evening, good evening. Right, so we are here today for the INICET marathon series. We do it after before every exam, and obviously after the exam we'll do our recall sessions and all. But then this is one of the most important session before the exam to brush all the important concepts in the rapid revision style and the most proficient fashion that we can actually give it to you. Okay. So without wasting any further time, let's quickly start. So you'll have a lot of pre-written material so that you don't waste time. Your job is to listen, concentrate. I'll be throwing questions at you. You have to catch those questions and just give the answers back. And you have to revise with me. You have to utter with me. And every single time I ask you a question, before I answer, you should be able to answer it. All right. So can we start? Chalo. So in the first topic, we have drains, right? In general, when you talk about drains, I'll just quickly give you a small component about drains. Many a times they have asked you a lot of questions on drains, so we'll keep it very simple. So when you talk about drains, drains work on the principle on whether it is an open drain or a closed drain. Whether it is an open or a closed drain. What is an open drain is, you will see that the collection will be let out. There is no chamber to collect, right? Closed drains will again work on two principles. One is your active drain. Another one is your passive drain. Active, I will be using negative pressure or I will be using suction pressure to collect it, and passive will be purely because of capillary gradient or difference in pressure, right? So the drains, whenever we say, if there is no chamber to collect, it is open. On the other hand, if there is a chamber to collect that collection or that drain, that is going to be your closed system drain. In the closed system, one you're using a negative pressure, that is called as the active drains, and one which you don't use negative pressure, they're called as passive drains, right? Now in that context, we have the following drains which are available. You can see the first image, you can see this is your orange color. Orange color is basically latex, and you can see there's no chamber. It is just a drain which is put. There's nothing which is collecting, so it is going to be an example of an open drain. Now you can see we have marked it here. So this is an open drain. I'm not using any pressure. It is passive. This is what we call as a corrugated latex drain. How do you know it is latex? If it is either yellow or orange in color, I can say that it is going to be latex in color or in latex. Another one you can see, this is like a tube. We don't use it that often right now. This is what we call it as a pen rose drain. Again, the material used to create that is latex. That is going to be rubber. Again, there is no, I would say, collecting system. So it is an open drain. There's nobody sucking the drain out, so hence it is also an example of a passive drain. Another version of a corrugated drain will be like this. These are pleats of corrugated drains. They are actually sheets. Now, because you can see transparent color, I can say it is silicon. The green line that is present is a radio opaque line. So this is an example of a corrugated silicon drain, and this is your radio opaque line, right? Then you see this is one of the most important and a famous drain that has been asked in an exam, and again has a very high potential to be asked in INI. See, INI, they love questions like this. What is this? You can see there is a collecting unit, there is a tubing structure which is present, so it is a closed system drain. I press this, while pressing it, the air is sucked out and it will try to pull that air back on. So hence it is going to be an example of a negative suction drain. So what is this drain? This drain is an example of a Romovac drain. I mean, the name is called as Romovac. It is a closed system active drain because it is using on a negative suction principle. You're not supposed to forget that. Is that clear? Then comes this. This, who can forget it or who can even overlook this? This is a Foley's catheter. But what do they ask you in Foley's catheter? In the Foley's catheter, you see the two openings which are present here. One which is going to be having a color code. This is what we call as a balloon inflating channel. This is the urine collecting channel. This is the eye from where the urine is going to pour into the tube, and there's a balloon which is present. When I inflate it, the balloon is going to inflate. So hence it is called as self-retaining Foley's catheter. Now, the Foley's catheter size color codes have been a previous exam question. Remember, Gori is very beautiful is the mnemonic. I'm not saying that every Gori is beautiful, but for the sake of understanding or just for the sake of exam, याद रख लो कि Gori है तो beautiful है, वरना जरूरी नहीं है. So Gori is very beautiful. G stands for green, O is orange, R is red, Y is yellow, V is violet and blue. These are the French in size, 14, 16, 18, 20, 22, 24 Frenches in the same sequence that you have to remember. What is a French is your previous exam question. Again, INI वालों ने ही पूछा था कि भैया ये French क्या है? ये French क्या है? What is this French? It is not the French from outside, right? What is the French? The French is equal to the outer diameter of the catheter. How much is one French? It is 0.33 millimeters is one French. So 0.3 millimeter is equal to one French. French is nothing but tube का जो outer diameter होता है उसको आप French बोलते हैं. ठीक है? Now that is in the terms of Foley's catheter. Next, you see there's another tube that is present which is called as a T tube, again because it is looking like a T tube. I mean the English letter T की तरह दिख रहा है तो इसको T tube बोल दिया है. Silicon से बना हुआ है. Again it is used for CBD exploration. So it's a T tube. It's a silicon drain. Again it is used for CBD repairs and surgery. Remember जब भी आप T tube डालते हो you will remove the T tube in 10 to 14 days, not before that, because I want the T tube to create a tract between the peritoneum and the bile duct. So when you pull the T tube, the tract is going to collapse. It's going to create a self-sealing mechanism. क्योंकि जब आप T tube निकालोगे ना, तो T tube को ऐसे ही खींच दोगे. और जब आप खींच दोगे तो CBD में छेद रहेगा. और वो छेद बंद कैसे होगा? वो छेद ऐसे बंद होगा कि जो पेरिटोनियम के साथ ट्रैक्ट बना हुआ है वो 10 दिन के बाद बनता है. तो 10 से 14 दिन में ये ट्रैक्ट बन जाएगा and then it will collapse. So T tube can be removed without having any re-exploration. CBD में जो defect है वो भी अपने आप close हो जाएगा in the same context of that. ठीक है? Now Foley's catheter का एक बड़ा भाई है, उसको बोलते हैं 3 ways Foley's catheter. You can see 1, 2, 3 3 ways है. क्या क्या है? कलर्ड वाला है वो बलून चैनल है, इससे आप हवा भरोगे और इससे आप फ्लूइड भरोगे, आपकी मर्जी है. लेकिन अच्छा एक और इंपॉर्टेंट क्वेश्चन, इन ऑर्डर टू इन्फ्लेट द Foley's catheter, व्हाट वुड यू लाइक टू यूज? द फ्लूइड ऑफ चॉइस टू इन्फ्लेट Foley's catheter. क्विक फीडबैक ऑन द चैट बॉक्स. Fluid of choice to inflate Foley's catheter. What is the fluid of choice? Quick feedback. और I can say मैंने तो आंसर ही दे दिया भाई, फ्लूइड बोल दिया ना तो एयर तो यूज नहीं करोगे. Which fluid will you use? Will you use distilled water, normal saline, ringer lactate, colloid, crystalloids? क्या डालोगे? What would you like to put it in? Somebody saying distilled water. Absolutely spot on, beta. Correct answer. You are going to use only distilled water because if you use crystalloids, it will form crystallines and that crystals will cause obstruction to the eye when you want to deflate the balloon and hence causing the retention of the Foley's catheter. So Foley's catheter के लिए the fluid of choice to inflate is going to be distilled water, and 3 ways Foley's catheter में. The first one is the colored one is going to be balloon inflating channel. जो सबसे बड़ा है इनमें से the मोटा, the biggest or the largest one is going to be urine collecting, and the third one is the irrigating channel. Why would you like to irrigate it? Whenever you have done any bladder surgery or whenever you've done a prostatectomy, in order to rinse that area off for bladder irrigation, I'll be using a 3 ways Foley's catheter. फिर आपको दिखेगा कुछ ऐसा ट्यूब ब्लू कलर का with a fenestration and then it is turned. This is like a twisted tail. It is called as a pigtail catheter, as we have already mentioned it. This is a pigtail catheter. Now pigtail catheter और DJ stent का फर्क क्या है? How do you differentiate? In pigtail you can see coiling only at one end. DJ stent you will have coiling on both ends. DJ stents are put whenever you are going to go for ureteric surgeries or ureteric repairs. DJ stent ka removal period is an exam type question. It has to be removed after 2 weeks. So removal period for the DJ stent. The removal period for the DJ stent is after 2 weeks. It is going to be after 2 weeks. Then comes your famous question, क्या है ये tube? ये जो आप बहुत commonly use करते हो. What is this? This is your nasogastric tube, which is also called as Ryle's tube. Few important questions. Ryle's tube का length कितना है? It is going to be 100 centimeters and 1 meter. What are you going to use for? It is going to decompress the stomach and you can also use for feeding. How do you know how much amount of Ryle's tube has to be pushed into the body? How do you measure the adequate length? Adequate length push करने के लिए हमारे पास next rule है. What is the next rule? You take the tube, measure from the nose to the tip of the ear, from the tip of the ear to the xiphisternum. Nose, ear and xiphisternum is called as next rule. जितना ये length आएगा उतना आपको अंदर push करना है, and that is how you take care of your nasogastric tube. Is everybody clear with that? ठीक है. Then comes Foley's catheter से inspired एक और हमारे पास है, which is called as a double balloon catheter, which is called as Syngaskin-Blakemore tube. Syngaskin-Blakemore tube मैं आपको बार-बार बताऊंगा that it is going to be used in order to control the bleeding from esophageal varices. इसमें आपके पास 2 balloons है, एक esophageal balloon, दूसरा gastric balloon है ना. अच्छा, esophageal balloon will be inflated with how much amount of air? It is going to be 40 millimeters of mercury pressure. Gastric balloon में 300 ml of air. याद रखना Sangaskian Blakemore tube, we use air. Foley's catheter, we use distilled water. Foley's catheter, I want the catheter to be down. I want the weight. So hence I'm using fluid. In Sangaskian Blakemore tube, if you recall it, SBT tube हम कहाँ use करते हैं? For bleeding esophageal varices. So this is the esophagus. This happens to be the stomach, and then into continuation to duodenum. And where are your varices? The varices are present in the lower 1/3 of the esophagus and the fundus of the stomach. Now, when I'm putting a Sangaskian Blakemore tube, the tube is going to go across here, and when I'm going to inflate the balloon, I want one balloon to be inflated at the level of esophagus to block the varices. Another one is at the level of stomach to block the stomach varices. Now, as you can see, I want the balloons to be at the gastroesophageal junction, जो ऊपर है. If I fill up with fluid, they'll become heavy, they'll drop down. So hence, I will be using only fluid to inflate these balloons. As simple as that. हाँ, सवाल ये है कि कितना आप, how much amount of air you're going to use it. For esophageal balloons, we use a 40 millimeters of mercury pressure. For gastric balloons, I'll be using 300 ml of air in order to inflate the balloons. As simple as that. Now, one precaution, that balloon must be deflated. Balloon must be deflated 12th hourly. The balloon must be deflated every 12th hourly. क्योंकि अगर आप balloon को deflate नहीं करोगे, or if you don't deflate the balloon every 12th hourly, it is going to result in pressure induced necrosis. So hence you have to deflate the balloon every 12th hourly. Now this was also your previous INI question. ये एक bulb दिया हुआ था, then there was a tubing, then there was fenestration. This is what we call it as a Jackson-Pratt drain. So what is Jackson-Pratt drain? It's an example of a closed system drain because there is this balloon. If I press it and leave it, धीरे धीरे जैसे expand करेगा. As it expands slowly, it will create negative pressure, and as it creates negative pressure, it will suck the fluid out. So hence, it is an example of an active drain. Is everybody clear with all the drains that are available? So these are 11 drains, their images, their properties that you should be aware of. Is everybody clear with that? A quick feedback. Quick feedback. ठीक है, चलो. Now going on to your cannulas, color code, flow rate. This has been asked multiple times. So एक simply देख लेते हैं क्या क्या cannulas है, क्या क्या color code है, उसका flow rate कितना है. So you have orange colored cannula, which is going to be at 240 ml per minute. Then you have gray colored cannula, which is going to be, when you look at the sizes, yes, these are important. So look at this orange colored cannula is going to be how much? It is going to be your 14 gauge. Gray is your 16 gauge. Green is your 18 gauge. Pink is your 20 gauge. Blue is going to be your 22 gauge. Yellow is going to be your 24 gauge. And violet is going to be your 26 gauge. If you have difficulty remembering these color codes, the easiest way to remember is this small diagram that we have. The core of the earth is made up of lava. Lava is orange. Orange is 14 gauge. Then soil आता है, उसके बाद soil is grey in color, 16 gauge. Green trees 18. Pink flowers is 20. Blue sky 22. Sun is 24/7. Yellow it is 24 gauge. Violet is universe, which is 26 gauge. Just in case आपको लग रहा है कि universe का feel नहीं आ रहा, मैंने आपके लिए stars भी बना रखे हैं. So stars will tell you that you're looking at universe per se. ठीक है. Now, when you look at the color code and flow rate, again, you have orange colored cannula, a 14 gauge needle with a flow rate of 240 ml per minute. Then you have gray, which is 16 gauge at 180 ml per minute. Green, which is 18 gauge, which is 90 ml per minute. Pink is 20 gauge, which is going to be 60 to 65 ml per minute. Blue is 22 gauge, which is going to be 30 to 35 ml. Yellow is going to be 24, which is 20 ml per minute. And violet is going to be your 26 gauge, which is 12 ml per minute. Okay? So this is all in all that you should know in the context of color codes and cannula and their flow rate. इस पे एक सवाल every alternate session में फंसता है, अभी भी आएगा. Take that into consideration. Then you have all these images. Okay? These are instruments. A quick recap of all the images you have. The first one, it is a needle holder. पूरा नाम क्या है needle holder का? Mayo Hagar needle holder. You are going to hold the needle. Where would you hold the needle? The junction between the 2/3 and 1/3. बेस से 1/3, टिप से 2/3 के जंक्शन पे आप नीडल को लगाओगे, उसको बोलते हैं the locking position of the needle or the needle holder. ठीक है. Now when you look at the entire context, this locking component is called as ratchet. ये आपका finger holding है, इसको आप shank बोलोगे. This is joint and this is the mouth of your instrument. Needle holder का एक sophisticated version है which is used for fine surgeries, which is called as a Castrovigi needle holder. I have mentioned in front of you. Castrovigi needle holder में spring mechanism है, इसको आप पकड़ोगे, it is going to lock it. There is a latchet here, it is going to latch like this. ठीक है, ऐसे latch कर जाएगा. Needle holder को पकड़ के रखने की जरूरत नहीं है, because it will hold the needle and it will lock it, and then you can do your work, and then you press it again, it will unlock yourself. So spring की तरह ऐसे lock होगा, फिर unlock होगा, lock होगा, unlock होगा. This is a Castrovigi needle holder. Now this are your forceps. Now always we get confused between this, that is your Gillies tissue holding forceps, and the Adson's tissue holding forceps. Adson mein you see there is one single tooth, and in Gillies forceps you will also see one single tooth, but again there's a longer one, and whereas in your Adson's it is shorter one. ठीक है, तो mouth जो है it is very short in Adson's, Gillies में it's a very long mouth. That's the difference that you need to keep. Then you have the Brown Adson's tissue forceps. Brown Adson's और Adson's में फर्क क्या? Adson's में there is only single tooth. Here you have multiple serrations. That's the difference that you need to have. Then you have 𝐑𝐄𝐂𝐻's tissue forceps. 𝐑𝐄𝐂𝐻 tissue forceps does not have any tooth. It will have very light serrations. These are atraumatic forceps. We use it to hold soft tissues, right? Then you have, this is your basically artery forceps. It's a curved artery forceps called as the Adson's curved artery forceps. Now this is your sinus forceps. How do you differentiate between curved Adson's or Adson's and sinus forceps? बड़ा simple है, बेटा sinus forceps में ratchet नहीं होता है. There's absence of ratchet in sinus forceps. On the other hand, ratchet will be present in other instruments. Artery forceps में क्या? It will be curved. It is straight. ठीक है, that's the difference that you have. Then you have Alice forceps, which is a tissue holding. You can see it is going to have an interlocking mechanism that is created in this particular format. This will lock like this. ठीक है, जो Alice forceps है उसके tooth ऐसे होंगे. They lock like this, right? You can see it in this image. They also have ratchet. They also have mouth and tooth. This is the same context. Babcock's, again, it is like the handcuff. It is like this. ठीक है, Babcock's is like this, right? You hold it all your bowel. Usually appendix को hold करने के लिए you will be using the Babcock's. Then you have the triangulated end. अगर आपको मिला है इसको बोलते हैं duval forceps. They're also called as the lung holding forceps. The duval forceps, they're also called as the lung holding forceps because they are atraumatic in nature. Then you have, if it is straight and there is a छोटू hole, this is called a sponge holding forceps. लेकिन अगर भाई थोड़ा सा आपके curve के साथ आएगा, you will call it as the ovum holding forceps. Ovum holding forceps में ratchet नहीं होता है. ठीक है, there is no ratchet, whereas in sponge holding forceps you will have ratchet. Ovum holding में there is no ratchet. That is a difference that you have to remember. Then Deva's retractor, it is again a very famous one. You can't miss across it. इतना बड़ा सा retractor है. ठीक है, it is like this. You put it and you retract it. This is called as a Deva's retractor. लेकिन अगर थोड़ा sophisticated है, right angle की तरह है, straight वाला, इसको Langenbach बोलेंगे. लेकिन थोड़ा सा wide mouth हो गया और curve के साथ मिलेगा, इसको आप Morris retractor बोलोगे. Then you have, in one end there is looking like a Langenbach, other there is a tooth like this. Langenbach एक end पे, tooth एक end पे, इसको बोलते हैं Zerni's retractor. It is called as a Zerni's retractor. Same, if you look at your previous retractor that you called as the Morris retractor, Morris retractor का अगर मैं curved version बना दूं, उसको Doyne's retractor बोलते हैं. It comes like this context, and there is one lever here which is to hold. So you want to hold it with the grip. It allows you to have a better grip. That is called as the Doyne's retractor. This has been your previous exam question. Needless to ask you, it is called as your Joll's self-retaining thyroid retractor. It is called as the Joll's self-retaining thyroid retractor. Now this again you can see there are tooths which are going to be facing outwards. This outward facing tooth is called as a mastoid retractor. Use it for head and neck surgeries very often. Then you have for abdomen self-retaining retractors. This retractor is very important. This is called as a Gallagher's self-retaining retractor. Gallagher में क्या है? There is a solid plate. ठीक है, लेकिन अगर इसी प्लेट में होल मिलेगा उसको आप बेल्फोर बोलोगे. सेम ऐसा ही है, लेकिन इस प्लेट में अगर आपको होल मिलेगा उसको आप बेल्फोर बोलोगे. बेल्फोर is also an example of a self-retaining abdominal retractor. This is your Mayo curved scissors for tissue cutting. That is pretty evident. Now, these are your spotters which they will usually ask in our exam. The first spotter is the swelling. There is a small black dot on the top of the swelling which is called as punctum, and more importantly it will have no hair. This is your sebaceous cyst. So there will be presence of punctum over the summit of the swelling. Hair above the swelling will be absent. अगर hair present है On a sebaceous cyst, it cannot be sebaceous cyst. For a sebaceous cyst, two important criteria. One, there has to be a punctum. Second, there has to be hair loss. Look at the lipoma. Lipoma is also called as a universal tumor. It is benign if there is presence of multiple lipomas. They are called as the Derkham's disease, which is also associated with pain. The hair over the swelling in lipoma will be present. Any slip sign is positive. What is slip sign? You try to touch, the swelling slips away, right? You press the swelling at one end, the swelling just completely moves. This movement of the swelling is what we call it as the slip sign positive. If you're swelling at the suture lines where your bony sutures are meeting, especially on the head and neck region, these are called as the dermoid cyst, which is present at the angle of the eye. This will be your angular dermoid. This again a congenital swelling. Since birth the baby will present. It is called as cystic hygroma. Now cystic hygroma is the overall most common site is going to be the posterior triangle of the neck. It is due to the sequestration of the jugular sac. There will be a positive transillumination, and the treatment of choice here is sclerotherapy. You can use an OK438 solution for sclerotherapeutic agent. This again a congenital swelling. Baby is born with this. There's an abdominal wall defect, but there is the content of the abdomen is coming out, but there's a membrane which is covering that area, and that is what we call it as omphalocele. Same thing if there is a defect with the bowel exposed. This is called as gastrocesis. In gastrocesis, what you'll do to examine the bowel, I'll put a plastic bag, that is nothing but a component, and then I'll fill that bag with the saline so that I can inspect it, and slowly I will reduce this so that the content moves inwards, and then you can basically cover up the defect. Okay? This is what we call as gastrocesis. Correct? Now, this is a sebaceous horn, a very famous image in your Bailey and Love textbook also. This is how it is going to appear to you. Now, this ulcer is what we call it as a venous ulcer. How did I tell you that it is a venous ulcer? Very important, very easy. First, it will be present in gaiter's area, that is below the level of the knee, that is around the level of ankle. Above the medial malleus, this ulcer will have sloping edge. It will be shallow. It will have pale, scanty, unhealthy granulation tissue, and this is because of ambulatory venous hypertension, that is your varicose vein. This, if you have a spotter, there's a tuft of hair at the back. This is going to be spina bifida occulta. Now, this test, again, your previous exam question, a brilliant transillumination is positive. The transillumination test is positive in hydrocele as well as in cystic hygroma. In hydrocele, the surgeries, we have already discussed it, is going to be Lords and Jabulois. Lords is sac plication, Jabulois is sac eversion. Jabulois is preferred over your Lord surgery. So, this concludes your common spotters as swellings and instruments. Is everybody clear with this? I know I'm going a little bit fast, but I don't want you to spend a lot of time. It should be just a quick recap so that you're prepared for your exam. Is that clear? So far, any questions, quick feedback? ऐसा कुछ है जो आप मुझसे पूछना चाहते हैं? Is there anything that you want to ask? Chalo. Now we're going into minimal invasive surgery. Now, in the exam, they'll give you images like this. The hollow structure will be called as port, and the solid structure is what we call as trocar. A trocar is something like this. It will be a solid component. It's sharp, it is solid. Trocar is solid and the port is hollow. Together they form as one single unit. You put the entire device inside and pull the trocar out, leave the port in situ. Now, there are two standard ports that you have. A bigger one is called as a 10 millimeter and a smaller one is called as a 5 millimeter port. Now, during the port, how do you place the port? So, in order to put the ports first, obviously you have to create pneumoperitoneum. In order to create pneumoperitoneum, you have to use a needle that is called as Veress needle. We have the Veress needle. I'll show it to you. We'll come back to this component. Let's look at the quick images first. This is what we call it as a lens. Lens is attached to the camera and this goes in. The most common angle of the lens is your exam question. As I've told you here also, this is going to be 30 degrees, right? The lens which you use is usually a 30-degree telescope. Now, as I told you, with the trocar and the port, because trocars are sharp, they can cause injury. So, you have an atraumatic trocar, which is going to be having a blunt, rounded edge. And this is what we call it as the Hansen's port. This is called as an Hansen's atraumatic port. Now, this is your repeat exam question. Ye kaun sa needle hai? You can see this needle is what we call it as a Veress needle. ठीक है. Now, Veress needle is used to create pneumoperitoneum. What are the questions that they ask you? It helps to create pneumoperitoneum. We all know this. Second, the most common gas used to create pneumoperitoneum is carbon dioxide. This also we know it. What is the initial flow rate in order to create pneumoperitoneum? It is going to be 1 to 4 liters per minute. How much can be the maximum flow rate? It is going to be 20 ml per minute. What should be the intra-abdominal pressure during surgery? It is 12 to 15 millimeters of mercury. And the entry, whenever you're inserting the Veress needle, when you're putting it, would you like to point towards the pelvis or towards the xiphisternum? It is always towards the pelvis. The angle between the needle and the skin was previous exam question, that is 90 degrees. And the angle between, I can show you here. When you're inserting the needle, so obviously the angle between the needle and the skin will also always be 90. But the angle between the needle and the body will always be at 45 degrees. So when you're inserting the needle, I will pinch the abdominal wall, I'll pull it up and then insert the needle. So angle between the needle and the skin is 90, but needle and the body is going to be 45 degrees. All these are your previous important questions. Now, whenever you're putting a Veress needle, you go through the umbilicus to create pneumoperitoneum. Lekin if a patient has already had, if the patient has already underwent a previous laparotomy scar, okay, if there is a laparotomy already there, can you put a Veress needle in the midline? The answer is no. So where will you put? You will put in the left subcostal space, which is what we call it as the Palmer's point. So Palmer's point, we are going to insert the Veress needle if a patient has underwent a laparotomy. If a patient has underwent laparotomy. Okay. Now, whenever, let's say you're putting a Veress needle, if there's a vascular injury, you're inserting the needle and suddenly the blood starts gushing out. What will you do? Do not panic. Keep the needle in situ. Convert the surgery that is you're trying to do into open. Don't do a lap surgery. Convert it to open. Control the bleeding. So do not pull out the needle is the advice that we give you. So the vascular injury can be because of port or can be because of Veress needle. You'll follow this maneuver. Keep the needle of port in situ. Convert into open and re-explore. Now, these are your recent exam question. Again, a little bit of bouncer, but important. Okay. Now, when you look at this angles, there are different angles which you have. The one which you're going to put the camera is called as the optical axis or the optical port, and these are called as the working ports. The angle between any of these instruments, that is your working instrument or a camera, and the body, the angle between the instrument and the body is what we call it as the elevating angle, which should be at 60 degrees, right? The angle between any of the working port and the camera is what we call it as the azimuth angle, and the azimuth angle is at 30 degrees. The angle between the two working ports is what we call it as manipulating angle, and the manipulating angle should be at 60 degrees. The manipulating angle should be at 60 degrees. Okay? So what is an elevating angle? It is the angle between the instruments and the body. What is an azimuth angle? It is the angle between the working port and the optical port, that is camera. What is the manipulating angle? It is the angle between two working ports. As simple as that. So how much will be the angle? It is 60 degrees. Elevating is 60. Manipulating is 60. So दो azimuth angle मिला के एक manipulating angle बनता है, तो obviously 30 degrees will be your azimuth angle. 30 together is 60. 60 is your manipulating angle. ठीक है? So that is about your minimal invasive surgery. Okay. So for any doubts, any questions for MIS, that is your minimal invasive surgery? So the next one is your energy devices that we have. Now in the energy devices, okay, in the energy devices, what do you have? You have monopolar, bipolar, harmonic and thunderbeat. Okay. Now, on what energies do they work? How do you know it's a monopolar, bipolar? Monopolar, there is single pole. Bipolar, there are two poles. Harmonic, there are no buttons. Whereas thunderbeat will have two buttons, which are going to cause alternate source of energy that is going to be driven. Now, monopolar works on electrical energy. Bipolar works on electrical energy. Harmonic works on vibrating frequency. Thunderbeat is combined, that is both electrical as well as vibrating energy. So we will see their ability to see cut and coagulate. The monopolar cauteries can cut as well as coagulate. Bipolar can only coagulate, not cut. Harmonic can cut and coagulate. Your thunderbeat can also cut and coagulate, right? Now the question that is asked is, in your harmonic scalpel, what is the vibrating frequency? It is going to be 20 to 50,000 hertz. Which energy device is considered to be safest in a patient with pacemaker? It should be a non-electrical energy devices, because the electrical energy will interfere with the pacemaker setting. So henceforth, in order to keep it better, you will use an energy source which is not having any electrical impulses, that is your vibrating energy, that is your harmonic scalpel. So harmonic scalpel do not interfere with the calibration of pacemaker, hence it is the safest energy device for a patient with energy or the pacemakers. Now, usually they ask you how do you differentiate between a cut and a coagulating current. You look at the cut current, you have the coagulating current. This is the graph that you have. In the cut current, voltage, see, we are going to plot the graph between the voltage and the frequency. There is low voltage but high frequency, that is cut current. In coagulating, there is high voltage but low frequency, that is your coagulating current. So that's the question that they ask you for energy devices. Suturing rule, everybody knows it. I'll just quickly run through them. What should be the length of the suture material? It should be 4 times the length of the wound. If this is the length of the wound, in order to suture, let's say this is 10 centimeters, you require a 40 centimeter suture material. Depth of the wound is important to determine the distance between the two sutures, entry and the exit of the needle. So whatever is the depth, the entry and the exit of the needle is determined by the depth, and distance between two sutures is also determined by the depth of the wound. The angle between the needle and the skin at entry is 90 degrees. We learn in laparoscopy everywhere it is same. Distance between two sutures should be twice the depth of the wound. We have already given you that answer. And the length of the suture ear, that means after cutting the suture thread, whatever is thread that is left behind is what we call it as suture ear. The length of the suture ear should be around 1 to 2 millimeters. The length of the suture ear should be around 1 to 2 millimeters. Okay? So that's the basic objective of the suturing rule. Now, what are the suturing techniques? We have again repeat exam question, we'll go quickly. If it starts from one end, continuously goes to other end knots, it is called as simple continuous running suture. This is your simple continuous running suture. If you start at one end, tie on the other end, single prick, it is called as simple interrupted. If you have 2 pricks on one end, 2 on the other end, then you knot it. And if you look at the direction, this is the direction of the suture, this is the direction of wound. If they are perpendicular to each other, this is called as the vertical mattress. And if they run parallel to each other, this is what we call it as the horizontal mattress suture. If you don't come on the surface of the skin, goes into dermo-epidermo junction, this is what we call it as the subcuticular sutures. The subcuticular sutures has the best cosmetic outcome. It has got the best cosmetic outcome. This has got the best cosmetic outcome. Okay, sorry. I mean, a little bit of age catching up. There's some backache, cramps and all. I'm trying to keep it simple. We'll see. Chalo. There's a knotting technique, right? If there is single loop of knot, this is what we call it as half hitch. If there are 2 loops, which is called as grannies, again, this is same as your square and reef knot. Surgeon's knot, you can see here, there are 2 loops on bottom, 1 loop on top. Usually, the question is, how do you differentiate between grannies and reef knot? You look at here. In the grannies, this is the loop and these are the threads. One thread is going above, one thread is going under. Here also there is a red loop, one green thread is going under, another is going above. So अगर एक thread नीचे से एक thread ऊपर से जाएगा, if it is like this, one thread going under the loop, one going over, this is called as grannies. You come to the square knot or the reef knot. Square में this is the loop, both the threads are going under the green loop. ये आपका red loop मान लो, both the green threads are going over the loop. So either both the threads are going above or below the thread loop is called as your reef or the square knot. So grannies में एक thread ऊपर एक thread नीचे जाएगा. रीफ या स्क्वायर नॉट में दोनों थ्रेड ऊपर या दोनों थ्रेड नीचे जाएंगे. Remember, your half hitch grannies is unstable knot. I've given you the image here. Whereas your square knot or reef knot is stable. Surgeon's knot is the most stable knot. It has 2 loops on bottom and 1 loop on top. 2 loops on bottom and 1 loop on top. Okay. Now, what is the suture removal period? Again, that's your exam question. If these sutures are put on face, it should be removed in 3 to 5 days. For scalp, arms, it is 7 to 10 days. For your trunk, legs, hand and feet, it is 10 to 14 days. And the longest is going to be palms and sole, which is going to be 14 to 21 days. These are your suture removal periods, right? Then coming down to your pressure sores or the bed sore, or also called as decubitus ulcer. What is the criteria? Now, in order to understand the pressure sores or the decubitus ulcer, you need to understand that they occur because of a very simple phenomena which is called as sustained pressure. So, the pressure exerted over a certain part of the body is more than that of the capillary occlusive pressure, which is at 30 millimeters of mercury. then that patient will develop pressure ulcers. The risk factors are prolonged immobilization, bedridden status, wheelchair bound status. We have spoken about it. The most common site for the pressure ulcer is ischium, followed by greater trochanter, followed by sacrum. In the exam, they'll give you the images and they'll ask you to identify what grade of pressure ulcer are you seeing across here. If there is only erythema, which does not blanch on pressure, a non-blanching erythema is what we call it as grade 1. If there's a partial thickness skin loss, is grade 2. Full thickness skin loss, whereas subcutaneous fat is exposed, is grade 3. If there's an underlying structure being exposed or involved, it could be a muscle, a vessel, a tendon, a nerve, it is called as grade 4. And then if an ulcer is covered by slough or necrosis, that is called as an unstageable status. It is an unstageable status because the true depth of the ulcer cannot be assessed. For grade 1 and grade 2, we'll go with conservative management. In the conservative management, I'll give waterbed, frequent change in position. If a patient is bedridden, every second hour. If a patient is on wheelchair, it is going to be every 10 minutes. And then also ask the patient to have a proper skin care so that the skin should not be moist so that there is no secondary infections. Grade 3, grade 4 are unstageable. You'll go with cleaning and debridement, the first thing that you're going to do. And then we'll use VAC. VAC is an old term. We don't use it anyhow. Now we call it as negative pressure wound closure system. Everything that I've written in red is your exam question. The pressure exerted by the VAC or the negative pressure wound closure system is minus 125 millimeters of mercury. It is intermittent in nature. It allows you to clear the secretions, keep the wound dry, promote the granulation tissue, and more importantly, the dressings has to be done every 5 to 7 days. The frequency of dressing should be done in 5 to 7 days. The frequency of the dressing is going to be 5 to 7 days. So you need to change the dressing once in 5 to 7 days, hence lesser pain and discomfort to the patient. Okay? And also follow the conservative management protocol. This is about your pressure ulcers. Remember the other name for pressure ulcer, that is your bed sore and decubitus ulcer. You will forget decubitus ulcer, so remember the name as decubitus ulcer. Okay? That's an important aspect about your pressure sore. Now, these are your previous exam questions. Just give me a second. Okay. A little bit of adjustment. Okay. Oof. Some days are just not yours. Okay, fine. All right. We will give you the PDF beta. This PDF is for you only. I'm not going to keep it for myself, no? Right. Now, what are the definition of a daycare surgery? That is admission to discharge within 12 hours is what we call as daycare. What is overnight stay, admission to discharge within 23 hours? Short stay is within 3 days, that is 72 hours. The most common complication of a daycare surgery is going to be nausea and vomiting. And the most common complication for readmission after a daycare surgery is hemorrhage. Please do not goof up on this. Is that clear? Okay. So the most common complication requiring readmission post a daycare surgery, it is going to be your hemorrhage. Okay. It is going to be a hemorrhage. Now, what is the criteria for discharge? What is the criteria for discharge in a patient with daycare surgery? The criteria for discharge: number 1, the vitals must be stable for at least 1 hour and patient should be oriented to time, place and person. The patient should get an adequate analgesia, pain control and oral medication should be there. Should have taken orally and tolerated well. Okay. Must have passed urine. There should be no bleeding, minimal discharge or soakage from the wound site. Able to dress himself, walk, and responsible person to take him home. If all these are satisfied, then you can send the patient home. That is the criteria for discharge. This has been asked multiple times, that is ERAS, that is your enhanced recovery after surgery, is what we call as the ERAS protocols. ERAS protocols are divided into preoperative, intraoperative and postoperative. What is the preoperative prerequisite? Number one, counseling of the patient, avoid mechanical bowel preparations, oral intake, solids are allowed until 6 hours and liquid are allowed until 2 hours. Clear carbohydrate rich liquids should be given, not any just liquids. Intraoperatively, we should always have minimal invasive surgeries preferred. Bupivacaine infiltration at the skin site so that the pre-sensitization of the skin will occur. Keep the patient warm. Nausea, vomiting prophylaxis. At least 2 classes of medication to prevent nausea, vomiting should be given. Post-operatively, use NSAIDs over opioids. Discontinue within 24 hours. What should you discontinue? IV fluids, start liquid followed by solids, and early ambulation. And then obviously avoid drains as much as possible. If you have put the drain, plan for early removal. These are your pre-operative prerequisites, intraoperative and post-operative in ERAS. That is your enhanced recovery after surgery. Usually whenever they want to ask the question, their questions will revolve around solids until what time it is acceptable, and liquids until what time it is acceptable. So solids for 6 hours, liquids for 2 hours. Okay? That is your ERAS protocol. Now, preparation of surgical site has been our area of interest in the exam. Number one, removal of metals and other foreign objects in preoperative. Why? Because they act as needles for infection, could cause thermal injury, and post-operative edema can cause, if you have a ring, right, and there's a post-operative edema in the upper limb, what is going to happen? The ring is going to constrict, so blood supply to the distal finger will cut off and hence causing problems, right? Hair removal is repeatedly asked. So what are the benefits? Number one, better for surgical site exposure. Application removal of bandages early is easy. Okay? Ideal time to do the hair removal is on the OT table, and it should be done with a trimmer. It should not be done with a blade or a razor, right? It's only clippers, that is your hair trimmer. Antisepsis is also important. In antisepsis scale, you can use alcohol based, that is chlorhexidine, or you can use whenever you're using it, the 3 methods you can use: concentric, horizontal or vertical. It does not matter. All of them have the same yield. Clean surgeries, incision site to away. That means when you're painting, always the side of incision has to be, the antiseptic solution has to be put there and then you move away. This is called as from the site, that is the incision site to the away site. For a contaminated wound, I will go from periphery to center. So I'll paint from the periphery and last the infected area and then discard it. Okay. Draping. When you look at it, draping again, first is always periphery, then 1 arm distance from the table. Avoid crossing over the tables, let it be an instrument or the drapes. Blunt tip clips to be used to fix the drape, not the sharp one. It should be blunt tip to fix the drapes. So these are the various components for the preparation of surgical site. Now, when you look at the incision, scalpel versus dithermy, to be very honest, both of them are almost equal. But if you have to give slightly higher, dithermy mein problem kya hai? Post-operative analgesic requirement is less. Okay? Whereas the surgical site infection, blood loss and operating time is same for both scalpel and dithermy, right? So the dithermy is incision and your scalpel is almost the same. When it comes down to incision, transverse versus longitudinal, transverse has lesser pain, better pulmonary functions and decreased risk for incisional hernia. Longitudinal incision will have more pain, decreased pulmonary function and increased risk for incisional hernia. So transverse incisions are better over your longitudinal incisions. Whenever you have a previous surgical scar and you're planning to do a laparotomy again on the same incision site, you should incise the above including scar. So you should include the scar in the incision and remove the scar along with it. Okay? Now, what are the named incisions? The first one you can see, it is a modified Blair's incision, which are going to be done for your parotid surgery. It's also called as lazy S. This is your Cock's incision, that is 1 centimeter below the cricoid cartilage, 4 to 5 centimeters above the suprasternal notch, and that is called as Cock's incision for thyroid surgery. I've given you all the incisions here. If you're opening the midline of the chest as median sternostomy. If you're opening a transverse incision in the chest, it is called as clamshell thoracotomy. If you're using incision from anterior to posterior, it is called as a posterolateral thoracotomy. If you're doing a midline incision in the abdomen, this is laparotomy incision. If you're going on top, you can see here, this is what we call as a rooftop or also called a chevron. For your appendix, that is McBurney's point incision, is gridiron. If you do a transverse, it is called as Lanz incision, that is more cosmetically acceptable. If you're using a curvilinear incision below the umbilicus, it is your Pfannenstiel's incision. And if you're using a curvilinear incision in the upper abdomen like a hockey stick, this is your 𝐒𝐿𝐾𝐄𝐝 incision for liver. That is your 𝐒𝐿𝐾𝐄𝐝 incision for liver, right? So these are with respect to all the different incisions that you're going to keep across. Somebody is asking, are you a doctor? Beta, I am a surgeon. Okay. Henceforth, I'm teaching surgery. I think that makes sense. Now, these are the different blades that you have. What is the exam question that they'll ask you is, what is the size of the blade for using laparotomy and thoracotomy? For laparotomy and thoracotomy, I'll be using a 22 size blade. For suture removal, I will be using your 12 number. So 12 number blade is for suture removal, right? For IND, stab and arteriotomy, I'll be using a 11 number blade and a 10 number blade for precise incision. These are your exam questions. ठीक है? 22 blade for thoracotomy and laparotomy. ठीक है? Suture removal के लिए 12 number blade. For INDs, for stab incision and the arteriotomy, it is going to be 11. ठीक है? Clear? So these are various blades that are available and their precise objectives. Chalo. Now, in the wound synthesis, we have collagen synthesis. Now, when you look at the collagen synthesis, what are the two important amino acids required for collagen synthesis? I've given both of them, that are proline and lysine. What is the process that undergo called as hydroxylation? What are the cofactors required for hydroxylation? That is vitamin C, iron, alpha-ketoglutarate acid. And they result in development of hydroxypurine, hydroxylysine, and they will result in collagen synthesis. Whenever you have deficiency of vitamin C or iron, this hydroxylation cannot occur. Hence, the collagen synthesis will not occur. Hence, there will be a poor wound healing, right? So, when you have a granulation tissue, which collagen is dominant? That is type 3. In early scar, again, type 3 is dominant. For initial scar, you have both type 1 and type 3 in a ratio of 1:1. In a final scar, you have more of type 1 collagen when compared to that of type 3 in a ratio of 4:1. In a ratio of 4:1. When you look at the scar strength, somebody is saying Arjun Reddy, but I'm no Arjun Reddy, I am Sandeep. If you want, I'm Serum Reddy Sandeep, right? You can compare it that way. Thank you for a little bit of ego boost, but appreciated, none the more. Looking at the scar strength, when you compare to the normal skin, any wound, at 1 week of wound, you will have 3% of the normal skin. At 3rd week, it will become 80%. And at 12th week, you have maximum, that is 80%. Theoretically, 90% is possible. 100% is never possible. Practically, the maximum scar strength you can have in a wound is going to be at 80%. It is going to be at 80%, right? So these are the various components of the scar strength with respect to time period. Again, important from the exam perspective. Now, in the post-op fever, again, quick recap on day 1, it is because of wind. That is nothing but, wind is nothing but air. Air is in your lungs. That is atelectasis of the lung. How do you prevent it? Ask the patient to, give chest physiotherapy, adequate analgesia, prevent smoking and steam inhalation. For day 2, day 3, it is usually water. Water is nothing but UTIs, that is a nosocomial infections or superficial thrombophlebitis. Day 4, day 5, it is usually the site of wound, that is surgical site infection. And day 5 is walking, that is because of DVT. So DVT, pain on day 5 is usually because of DVT. For day 6, it is burst abdomen. How do you know it's a burst abdomen? The criteria for burst abdomen is rectus sheath opens up, the bowels are exposed out. You will see a salmon colored fluid coming out from the wound site in large quantity. You know it as a burst abdomen. Take the patient for emergency. Put a Euro bag or Bogota bag and come back. Okay. Definitive is also going to be a rectus closure. Day 7 is your intra-abdominal abscess. Now, factors that result in development of the burst abdomen. Number 1, how do you know it's a burst abdomen? There is a salmon colored fluid coming out of the wound site. From a patient in surgical site, from a patient perspective, if there's a cough, constipation, obesity, immunocompromised status and poor nutrition can result in burst abdomen. From a surgical side, it is going to be incision if it is midline. If it is an emergency surgery over elective, if you have taken a continuous suture over interrupted, and a poor choice of suture material are the technical problems that can result in burst abdomen. Okay? Now, when you look at the surgical site infection, first of all, what is the definition of surgical site infection? Any infection in the wound within 30 days of surgery, or if there is an implant, example, any ortho surgery you have done within 1 year of surgery is called a surgical site infection. In order to assess the surgical site infection, you have two criteria: asepsis wound score and Southampton wound grading system. Both of them has been your exam question. Now, in asepsis wound score, A stands for additional treatment required for wound healing. S is your serious discharge. E is erythema. P is purulent discharge. S is separation of deep tissue. I is isolation of organism. And S is stay in hospital, that is inpatient for more than 14 days. This is your asepsis score. In Southampton wound grading system, grade 0, normal healing. Grade 1, there is normal healing with mild erythema. Grade 2, there is erythema with other signs of inflammation. Grade 3, clear serious discharge. Grade 4 is going to be purulent discharge. Grade 5, a severe wound infection with or without tissue loss, or there could be hematoma requiring aspiration. All of them are grade 5. Higher the grade, poorer the prognosis in the wound healing process. So this is in terms of wound infections and surgical site component. Now, this is something that I've been asking you again and again. That is the classification of surgical site or surgical wounds. We have divided them into clean, contaminated, and dirty. Very simple. Clean, what is the criteria? It should be non-traumatic, elective, no entry into natural cavity. I've given you all the examples. Clean contaminated is everything as clean, but now you're entering into your abdominal cavities, or I can say natural cavity. Contaminated are traumatic wounds, emergency surgeries, re-entry into natural cavity, under emergency situations, or all re-explorations will be contaminated wounds. Examples, this is important. Number 1 is going to be emergency appendicectomy, emergency cholecystectomy, open cardiac massage was a recent exam question, re-exploration, and bowel spillage during surgery. All of them are contaminated. Dirty if there's presence of pus or fecal matter, the abscess, fecal peritonitis, delayed open trauma, wound for more than exposed for 6 hours, intracutaneous fistula, all these are dirty wounds. As simple as that. When you look at the ulcers based upon their edge, which is metabolically the most active side, you can know the cause for that particular ulcer. If there's a sloping edge, that could be because of healing ulcers or venous ulcers. If there's an undermined edge, you can see here, it can be because of tubercular and necrotizing fasciitis. If there's a punched out ulcers, it can be because of syphilitic or trophic ulcers. If there is an ulcer which is going to have raised and everted, it is a squamous cell carcinoma of the skin, raised and beaded, it is going to be basal cell carcinoma, which is also called as the keratin pulse. Okay, this is in the context of ulcers. Okay, so this summarizes your first set of the topics in general surgery. So far, any questions? Quick feedback, guys. So far, any questions? Quick feedback. All right, so if you've got no questions, we're going to break it down for 5 to 10 minutes. So we'll take a short break. We will resume at 6:40. So what we'll do is, we have planned for 3 sessions, that is 1 hour each. So we'll do 1 hour, take 5 to 10 minutes break, and then we'll resume back another 1 hour, and then we'll continue to do so. Okay? Break for 10 minutes, we'll resume back. Alright guys, let's continue. Right, so next is going to be burns. In the burns, we have the standard Wallace rule, right? So the rule of 9 is for burns. This is the most commonly used rule, whereas the best is going to be Lund and the Broders chart. We're given a differentiation. The head and neck in the adult is going to be 9%, child it is 18%. Trunk by definition is chest plus abdomen, anterior 18 is posterior 18. In adults, the lower limb is 18, child it is 14%. Perineum accounts for 1% in adult, child there is no perineum, right? Now, based upon the depth of the burn wound, we have the criteria that are to be important. We differentiate that on the basis of whether it is a first degree burn, a second degree superficial, a second degree deep, a third degree or a fourth degree burn. Now, based on the structures which are involved, for a first degree it is only epidermis, as you can see here. Second degree is papillary dermis, secondary deep is going to be reticular, then you have third degree is full thickness skin, and the fourth degree is going to be underlying structures. Wherever the skin is there, there will be pain. So hence the pain will be present in first degree, second degree superficial, second degree deep, there is no pain, but there is pin prick sensation. Blisters are also associated with skin, so they will be present in first, second degree and second degree superficial and deep. Third degree, fourth degree do not have any blisters. Color is important. For first degree it is erythematous, second degree it is the superficial is bright red, secondary deep is going to be mottled pink or waxy white, and third degree is leathery, fourth is charred. Now third and fourth degree will not heal. The scar formation occurs from secondary deep onwards, and a scar will also be formed from secondary deep onwards. Now, for the calculation, you have two formulas. Number one is Parkland, another one is your ATLS. Parkland is now obsolete, we don't use it. So Parkland formula is out of the picture, right? Now we use only ATLS. For second degree, third degree, it is going to be 2 ml per kg for total body surface area burned. For child, it is going to be same, second degree, third degree is 3 ml per kg. For adult, it is 2 ml per kg, whereas for fourth degree or electrical burn, both child and adult, it is going to be 4 ml per kg per percentage of total body surface area burnt. If they ask you what is the most commonly used fluid, the answer is going to be Ringer lactate. But if they ask you colloid, it is human albumin solution. When should you infuse, or ideal time to administer is after 24 hours. How do you calculate is Muir and Barclay's formula, that is 0.5 into weight in kilograms into percentage of total body surface area burnt. Whatever you have calculated, that you have to administer it, and that is done after 24 hours in a 12th hourly period. So for the first 12 hours, you can give every 4th hourly, from there every 6th hourly, and then 12th hourly is the administrative protocols. Now, when you look at the topical agent, remember the most common topical agent used is silver sulfadiazine. The best is silver sulfadiazine with cerium nitrate because it can penetrate eschar also, right? We usually see their ability to be effective against Pseudomonas and gram-negative. Silver sulfadiazine is absolutely effective. The only problem with silver sulfadiazine is it cannot penetrate eschar. Coming to the optimum cytology criteria. In an optimum cytology criteria for a thyroid FNSEs, for a thyroid FNSE, what is the optimum cytology criteria? Number one, the size of the needle. The size of the needle is anywhere between 22 to 26 gauge needle, right? The minimum aspirate should be 2. The minimum number of follicles per aspirate should be 6. And the total number of follicles, cells per follicle that is present is around 10 to 15, right? When you look at the inflammatory thyroid swellings, we have 3 standard inflammatory thyroid swelling. One is the Hashimoto's, decurvence, and Riedl's. Remember, Hashimoto's and Riedl's are chronic. Decurvence is subacute. Hashimoto's is autoimmune. Decurvence is post-viral. Riedl's can be idiopathic or autoimmune. When you talk about autoimmune, you need to know the antibodies. For Hashimoto's is anti-TPO, whereas Riedl's is IgG4. Whereas your decurvence is cross-reacting antibodies due to post-upper respiratory tract infections, right? Now, the HLA associated with your Hashimoto's is B8, DR3, DR5, whereas B35 for your decurvence, there is no HLA association with Riedl's thyroiditis, right? Now, when you look at the age of presentation, you look at the Hashimoto's between 30 to 40. Decurvence at any age group, Riedl's is seen in elderly patients. All these disorders are more common in female. They all will present to you with swelling with symptoms of hypothyroidism, except for decurvence because it is inflammatory, subacute, so hence there will be painful swallowing. Initial thyroid status is important. So in Hashimoto's, there will be burst of cells, there will be increase, eventually there will be hypo. Decurvence irritation will cause more release in intermediately they'll try to rebuild the reserve, so hypo, eventually there'll be euthyroid. Read this from first time onwards. From the beginning itself, there is autofibrosis of the follicles resulting in hypo throughout its presentation. The investigation is same, ultrasound with TFT, with FNSC. Remember, for inflammatory disorders, do an FNSA to confirm, as well as with anti-TPO antibodies or IgG4 for renal thyroiditis. Management, all inflammatory thyroid swellings will do conservative management because surgically it is not possible because of chronic inflammation. There are a lot of additions, so lifelong thyroxine. Whereas your 𝐷-𝐄𝐈 is self-limiting, you don't need to really do anything across here. Okay. For inflammatory thyroid swellings, if there is severe pressure symptoms, we have discussed this before also. For an inflammatory thyroid swellings with severe pressure symptoms, the surgery of choice is going to be hysterectomy. The surgery of choice is going to be hysterectomy for the patients of inflammatory thyroid swellings, right? Now, in the comparative status for your thyroid carcinomas, right? In a thyroid carcinoma, one second, guys. Right, so I'll be comparing the papillary cancer, the follicular cancer, anaplastic, and the medullary cancer thyroid, right? Now, when you look at the origin, for papillary, follicular, anaplastic, it is follicles. For medullary, it is C cells. The most common thyroid cancer is your papillary cancer thyroid. The one with the worst prognosis is going to be anaplastic cancer. One which is most common in ectopic thyroid glands is your follicular cancer thyroid. And one associated with Men's syndrome is your medullary cancer thyroid, right? All these malignancies are more common in female. I've told you the gene mutation for papillary, remember BRAF, whereas for follicular cancer thyroid, it is going to be PTEN gene mutation, but more important is medullary cancer thyroid, that is your RET gene mutation. The risk factors for your papillary cancer thyroid is radiation, thyroid duct cyst, and maybe associated with Hashimoto's, right? Whereas for follicular, it is long-standing untreated goiter. For your medullary cancer thyroid, it is associated with Mentu syndrome. When you talk about papillary cancer thyroid, they present to you as solitary thyroid nodule-like presentation. They present to you as solitary thyroid nodule-like presentation of cervical lymphadenopathy. Follicular is thyroid swelling with pulsatile forehead bony swelling because of metastasis. Here, massive thyroid swelling with pressure symptoms in anaplastic. Whereas medullary cancer thyroid will be solitary thyroid nodule-like presentation with diarrhea due to paraneoplastic syndrome, where it produces more amount of 5-HT3, which is serotonin, right? The mode of spread, when you look at for papillary cancer, is lymphatics, follicular is hematogenous, anaplastic is direct. Medullary cancer thyroid will be lymphatics in association with hematogenous. In association with hematogenous, right? Most common site for metastasis for papillary is lungs, for follicular is bones. Again, for anaplastic is lungs, whereas for medullary it is going to be liver followed by bones, right? You look at the investigation standard for all of them is going to be ultrasound, TFT, FNSC, and tumor marker is thyroglobulin, except for follicular cancer thyroid, where the FNSC will give you Thy3 in origin. That is going to be follicular origin. Remember, FNSC cannot differentiate in follicular adenoma and carcinoma. Hence, lobectomy with frozen section has to be performed. For medullary cancer thyroid, the tumor marker is CEA and calcitonin. What are the important histopathological findings? Orphan nuclei, Samoma bodies in papillary cancer thyroid, whereas Ashkenazi cells or oxyphilic cells and follicular cancer thyroid, and presence of amyloid strands, which you can see here in your medullary cancer thyroid. Men syndrome, again repeatedly asked. Men 1 is what we call as Wermer syndrome, 2A is called as Sippel syndrome, 2B is called as your, obviously 2B is also called as Men 3 now, and the Men 4 is the new addition. Men 1, everything with P, that is your pituitary adenoma, parathyroid adenoma, and pancreatic adenoma. 2A is a Sippel syndrome, that is parathyroid adenoma with medullary cancer thyroid and pheochromocytoma. 2B is mucosal neuromas, medullary cancer thyroid, pheochromocytoma, and marfanoid habitus, and 4 is Men 1 with reproductive organ tumors. Men 1 is Men 4 is Men 1 with reproductive organ tumors. One second, guys. Okay. Going into breast, we have BIRADS, that is breast imaging reporting and data system. In BIRADS, again, is the same context. Remember, BIRADS, it is category 3, which is probably benign. The management for probably benign is follow up after 6 months. That is our exam question. Okay. In breast cancer, the TNM classification is important. As I've showed, T1 size less than 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters. T4A is involvement of chest wall. Chest wall is made up of ribs, intercostal muscles, and the serratus anterior group of muscle. T4B is involvement of skin. T4C is both chest wall and skin. And T4D is going to be inflammatory breast cancer involving more than 1/3 of the breast skin, right? Lymph nodes, we have, if there is N1, there is axillary node which is mobile, N2A is axillary node which is fixed, N2B is internal mammary group of lymph nodes, N3 is apical, N3B is both axillary as well as internal mammary, N3C is supraclavicular, M0 no evidence, M1 is distal metastasis, right? Now, usually the exam question revolves around what is 3A, 3B and 3C stage. If there's an N2 disease, it is 3A. If there's a T4 disease, it is 3B. And if it's a N3 disease, it is going to be 3C. It is going to be 3C, right? Now, how do you manage it? For stage 1, 2A, 2B called as early invasive, 2A, 3A, 3B, 3C is called as locally advanced, and stage 4 is advanced. For early invasive, we have surgery, either simple mastectomy or breast conservative surgery. Node negative disease, do a sentinel lymph node biopsy. Node positive, do a lymph node dissection. Whereas for locally advanced, we go ahead with neoadjuvant chemotherapy, modified radical mastectomy with post-operative adjuvant therapy. For palliative, it is only going to be, for stage 4, it is only going to be palliative care. The most common route of spread for breast cancers, as we all know, it is lymphatics, followed by hematogenous, followed by your direct route of spread. The most common lymph node involved is axillary group of lymph nodes. Most common site for secondary is due to hematogenic spread is bones due to Bateson's fluxus. The most common bone involved is lumbar vertebra, followed by femur, followed by thoracic vertebra. The most common type of secondaries that you'll see is going to be osteolytic secondaries in comparison to that of osteoblastic secondaries. When you look at the breast surgeries, in simple mastectomy, what are the structures we are going to remove? That is the glandular component, the stroma, nipple, and the areolar complex. For radical mastectomy, which is also called as the Halstead's mastectomy, you do simple mastectomy with level 1, level 2, level 3 group of lymph nodes with pectoralis major and the pectoralis minor muscle to be removed. For a modified radical mastectomy, you have patties, Scanlens, and 𝐒𝐿𝐴𝐻. 𝐒𝐿𝐴𝐻 is the most common type. In modified radical mastectomy, we don't remove the muscles, we remove only the pectoralis fascia. What are the structures preserved in modified radical mastectomy? Can be remembered as ABCD. A is your axillary vein, B is your Bell's nerve, C is your cephalic vein, D is your nerve to your latissimus dorsi. Complication associated with modified radical mastectomy, if it is immediate post-op, can be remembered as swab, seroma, winging of scapula, arm edema, and blackening or flap necrosis. The most common is seroma formation. If there's a delayed complication, which is usually after 5 to 10 years or 10 years beyond, you will see presence of lymphangiosarcoma of the same limb, that is ipsilateral limb, called as Stewart-Travis syndrome, associated with very poor prognosis. Now, in the vascular disorders, we have Burgess and atherosclerosis. On a comparative, the age for Burgess is less than 40, atherosclerosis is above 50. The risk factors for Burgess is smoking, atherosclerosis is obesity. Most common limb involved in Burgess, all 4 limbs are equally involved. Atherosclerosis, lower limb is far more common when compared to that of upper limb. The size of the vessel involved is small to medium in your Burgess, large to medium in atherosclerosis. The pattern of progression or involvement for Burgess is skip lesions, whereas atherosclerosis it is continuous. The progression in Burgess is from distal to proximal. Atherosclerosis is proximal to distal, that is reverse. Structures involved in Burgess, artery, vein, and nerve, whereas in atherosclerosis only arteries involved. ABP index is something we'll measure, that is systolic blood pressure over an ankle with respect to brachial artery. The normal ABP index is 1 to 1.3. For a calcified blood vessel, more than 1.3. Intermittent claudication is less than 0.9. And rest pain occurs at less than 0.5 and critical limb ischemia at less than 0.3. Now, management for atherosclerosis. If there's an iliac occlusion, then there will be bilateral intermittent claudication involving gluteus, thigh, and calf muscles. If there is a male patient, because the internal iliac supplies to male gonads, it will cause male impotency, and that is called as Leydig syndrome. For this patient, we'll do an biofemoral bypass with Dacron. If there is an iliac occlusion, there will be unilateral intermittent claudication involving thigh and calf. Here only iliofemoral bypass. If there is a femoropopliteal occlusion, there will be unilateral intermittent claudication involving only the calf muscles. And here we will do an iliopopliteal bypass using autologous reversed great saphenous vein. For varicose vein, the SEEP classification is something that they have asked you again and again on a repeated loop. C0, there is again SEEP classification, she is your clinical classification. C0, no evidence of venous disorder. C1 is telangiectasia or reticular veins. Telangiectasia is size less than 1 millimeter in diameter. Reticular is 1 to 3 millimeters in diameter. C2 is varicose vein. Varicose vein criteria is if it is more than 3 millimeters in diameter. C3 is going to be edema. C2R is recurrent varicose vein. C4A is presence of pigmentation. 4B is lipodermatosclerosis. 5 is corona phlebitica. C4C is corona phlebitica. 5 is healed venous ulcer. 6 is active, and 6R is recurrent venous ulcers. Right. E is etiology, P is pathophysiology, A is the system involved, not important. Investigation choices duplex, you will see a presence of Mickey Mouse sign where you have SFJ incompetency. Management, you can do Trendelenburg surgery, EVLA, RFA with perforator incompetency, you can do SEPS. Remember EVLA, that is endovenous laser ablation, the wavelength of the laser used is 1470 nanometers, and the radiofrequent ablation that we do, the temperature used is at 120 degrees Celsius at 20 seconds per cycle. One second, guys. Sure. If there's a venous ulcer, then we'll use a Bisgard's regime, that is educate, elevate, and usage of elastic compression stockings. Okay. So that is with respect to the SEEP classification and its management. In split thickness skin grafting, you should know what is a 𝐒𝐻 and a Wolfie's graft. 𝐒𝐻 is a partial thickness, Wolfie's is a full thickness. In partial thickness, we use epidermis and a part of dermis, and full thickness, we use the entire dermis along with epidermis, right? How do you know in partial thickness, you have taken a right amount of graft thickness, that is presence of punctate hemorrhage at the wound site indicates a right thickness, whereas if the subcutaneous fat is exposed, then you have taken the right thickness for full thickness skin grafting. When you look at a donor site, in a partial thickness skin graft, the defect remains temporary because it will re-heal back, whereas the defect becomes permanent in a full thickness, right? There will be no scar in partial thickness. Your full thickness will leave a scar behind it. You can take any size in a partial thickness, whereas only small graft is allowed in a full thickness. Repeat grafting from the same donor site is possible from a partial thickness, not possible from a full thickness. The most common site for graft extraction is going to be thigh, whereas it is going to be retroauricular and full thickness. The graft survival for partial thickness is good, whereas full thickness is poor. There are graft contractions, primary and secondary. Immediate is called as primary, secondary is after putting on the graft site or the recipient site. Remember, in partial thickness, there is more of secondary when compared to primary, hence cosmetic outcome is poor. Whereas in full thickness, it is more of primary when compared to secondary. So the cosmetic outcome remains better in full thickness skin grafting. Clear? The causes for graft failure, we have hematoma, seroma, repeated movement at graft site, infections and absence of periosteum. The most common is hematoma. How do you prevent that? By doing pie crusting. You can prevent the collection of both hematoma and seroma. Pie crusting also increases the graft surface area by around 1.5 to 6 times, right? If there is a repeated movement at graft site, you can do a slab, that is immobilization of the wound site to prevent the graft failure. If there is expected skin infection or the wound site infection, all that you have to do is a preoperative wound site culture. Presence of beta hemolytic streptococci is an absolute contraindication for skin grafting. Absence of periosteum, there is no vascularity left, hence the graft won't be accepted. For cleft lip and cleft palate, they usually ask you the repair time. If there's a unilateral cleft lip, it is repaired between 5 to 6 months. If there's a bilateral cleft lip, it is between 4 to 5 months. For a cleft soft palate, 6 months. For a hard palate, it is 15 to 18 months. For both cleft palate, which is hard and soft, you have to do 2 surgeries. At first surgery at 6 months for soft palate, second is for hard palate at 15 to 18 months. If there's involvement of both lip and cleft palate, then you have to do 2 surgeries. The first one is at 5 to 6 months where you are using lip and soft, and hard palate is going to be 15 to 18 months. The cleft lip and palate for bilateral cleft lip, you do 2 surgeries. The first surgery is at 4 to 5 months for both lip and soft palate. Second is going to be 15 to 18 months only for hard palate. Okay? Now, for a graft extraction, Matthews and A's classification is something which is new, which is important. If you are taking a flap, right? And what are the types that you have? In type 1, if there's only one dominant blood supply, example is tensor fascial lata. In type 2, there's one dominant and two axillary blood supplies, example is gracilis. In type 3, there are two dominant blood supplies, that is a gluteus maximus. Type 4, the multiple axillaries, no dominant sartorius. Type 5 is one dominant with multiple axillary, example is latissimus dorsi. It is going to be latissimus dorsi. Clear? So that's in terms of plastic surgery and its components. For nutrition, they have asked you what are the indications for total parenteral nutrition. The indication for total parenteral nutrition, number one is short bowel syndrome, where the length of the small bowel is less than 200. High output enterocutaneous fistula, where the output is more than 500 ml in 24 hours. Acute inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus beyond 72 hours. Now, what is the composition? For any TPN, the composition is going to be carbohydrates, fat, proteins, vitamins, trace elements. The maximum is carbohydrates. You'll see carbohydrates 40 to 50%. They give you an energy of 3.5 kilocalories per gram. They have asked you how much energy based upon the carbohydrate, fat and protein. You should know these numbers. You should be able to calculate the energy also. Fat is 30 to 40% and 9 kilocalories per gram. Protein is 10 to 20% with 4 kilocalories per gram is what the energy yield is going to be, right? So this is on the basic context of total parenteral nutrition. Clear? So far, any doubts? Quick feedback. Chalo. Moving on in terms of trauma. Again, few important questions. In trauma, they've asked you why is triage done? Triage is on the basis of outcome, not on severity. It's a color coding system which is going to categorize the patient based upon the least priority and the highest priority. Black color is least priority, the patient is broad dead. Red is the maximum priority, which is emergency or immediate attention is required. Yellow is going to be urgent, green is delayed, blue is going to be moribund, patient expectant, death has been status. Hemorrhagic shock, again, repeat exam question, the different classes based upon the percentage of volume loss. For class 1, less than 15%, class 2 is 15 to 30, class 3 is 30 to 40, class 4 is more than 40%. In class 1, everything remains normal, so no need to worry, only oral fluids are more than enough. In class 2, you see the heart rate picks up, blood pressure remains normal, pulse pressure falls, respirator is normal, urine output starts to decrease, GCS remains normal, start the patient on IV fluids. In class 3, everything is going to go haywire, heart rate increases further, blood pressure drops, pulse pressure drops, respirator picks up, urine output becomes less, that is oliguria. Patient becomes confused. Here, I'll start the patient on IV fluids as well as blood transfusion if required. Class 4, everything is in the reverse order. Heart rate picks up, blood pressure falls further, pulse pressure falls even further, respirator picks up, urine output becomes absent, that is anuria, patient becomes unconscious. Here you have to go with massive blood transfusion. The criteria for massive blood transfusion is to give PRBCs, FFP platelets in a ratio of 1:1:1:1. And what is massive blood transfusion? When you look at it, if more than or equal to 10 units of blood is transfused within 24 hours. More than 10 units of blood is transfused within 24 hours. This is what we call it as massive blood transfusion protocol, right? Now, head injury based upon GCS classification is important. Minor head injury is GCS of 15/15 with no loss of consciousness. Mild is going to be 14 or 15 with loss of consciousness. Moderate is 9 to 13 and severe of a GCS of less than or equal to 8. This is an indication for intubation. EDH was SDH, they have asked you multiple times. EDH, that is extradural hemorrhage, is a collection of blood between the dura and the skull bone. Absolutely, we all know it. It is usually because of the injury on the temporal side where you have 3 bony prominences that stereon fracture is going to occur. The most common source of bleeding is your middle meningeal artery and it is going to cause rapid increase in intracranial pressure. So there will be signs into the raised ICT with lucid interval. SDH is a collection of blood between dura and the arachnoid membrane. It is usually because of significant history of hit, fall or blow to the head. Usually occurs because of damage or the most common source is cortical bridging veins. They bleed slowly, the intracranial pressure will increase but it will be a gradual increase in component. For both of them, NCCT head is the investigational choice. Here you will have The lens or the lenticular shaped opacity is also called as biconvex opacity. Okay? The management is going to do craniotomy. Here in one surface is concave, another one is convex. So concavo-convex opacity, also called as your crescent opacity, right? Here, for large HTH, we would like to do a craniotomy. For a small HTH, we will just leave it across it. Whereas for chronic HTH, we'll do burr-hole surgery. These are the three indications that you should be remembering across. This has been your repeat exam question, that is your diffuse axonal injury, where there's a complete disruption of axon between the white and the gray matter. So patient goes into coma post head injury. CT becomes normal. So here you do an MRI. In MRI, you will have punctate hemorrhages between white and the gray matter associated with very poor prognosis. What is Cushing's triad? Hypertension, bradycardia with irregular respiratory rate because of raised intracranial pressure. What is lethal triad of trauma? It is going to be your metabolic acidosis with coagulopathy and hypothermia. How do you prevent metabolic acidosis? By giving ringer lactate as the fluid of choice. To prevent coagulopathy, whenever you're doing a blood transfusion which is in massive quantity, we'll go with PRBC, FFP platelets in the ratio of 1:1:1. Hypothermia, we give warm crystalloids to prevent hypothermia. Last year, the question was on damage control surgery. What are the various stages? Stage 1 is patient selection to know which patient requires a damage control, which will require an early total care. Stage 2 is to go for exploration. What is the goal? Control hemorrhage, prevent any further contamination, do a temporary abdominal closure. Then go to stage 3, ICU care, keep the patient for 24 to 48 hours, treat the coagulopathy, prevent the hypothermia, and then take the patient back into surgery. That is stage 4 is a secondary exploration or re-exploration. The goal for re-exploration, it is to correct the anatomy. Stage 5 is your definitive abdominal closure. In stage 4 also there is temporary abdominal closure. You don't close it on a definitive grounds. Now the status of shock has been important. So we'll try to quickly run through it. So I'll be comparing three shocks, that is your hypovolemic, cardiogenic and septic shock. For a quick component, this is your right atria, this is your right ventricle, this is your left atria, this is your left ventricle. This is the arch of aorta. Here you have the baroreceptors. Whenever the baroreceptors are going to get activated, they will cause activation of sympathetic system. Activation of sympathetic system will cause excessive release of epinephrine and norepinephrine. The effect of epinephrine and norepinephrine on the heart, it increases the heart rate. It increases the heart rate. Right? These are the vital organs. These are the non-vital organs. The blood pumps from the left ventricle into the aorta. From there it goes into vital. More amount of blood go to vitals, less to non-vitals. From there the blood is going to pool back here. And this we'll call it as the vascular pool. From the vascular pool, the blood is going to be pumped back into the right atria and this continues across. Okay? This is the circuit. Now, if there is a damage in the vascular pool, we call it as hypovolemic shock. Damage in heart will call it as cardiogenic shock, and the peripheral vascular resistance, which decides more amount of blood to vital, less to non-vitals, is what we call it as your septic or distributive shock. Let's try to understand what happens in hypovolemic shock. In the hypovolemic shock, as the blood starts leaking from the vascular pool, blood going into the right atria is less. The right atrial pressure is measured by JVP and the left atrial pressure is measured by pulmonary capillary wedge pressure. If the volume of blood going into right atria is less, so obviously right atrial pressure will drop, that is JVP. If the blood in the right atria is less, the blood going into right ventricle will also be less. That means the blood coming back into the left atria will also be less. Left atrial pressure is pulmonary capillary wedge pressure, it will be less. So blood going into the left ventricle will also be less. That means the preload decreases. If preload decreases, obviously I can say that the stroke volume is equal to preload minus afterload, and the cardiac output is equal to stroke volume into heart rate. Right. So obviously the preload decreases, the stroke volume decreases. If stroke volume decreases, the cardiac output will decrease. So hence the cardiac output in hypovolemic shock will reduce. If the cardiac output reduces, the blood pressure in the aorta will fall because the pressures in the aorta is maintained by volume. If the systolic blood pressure drops, the baroreceptors get activated, catecholamines, epinephrine, norepinephrine, hence the heart rate is going to pick it up. Now, as the blood available for circulation is less, I want more amount of blood to go to vitals, less to non-vitals, hence the peripheral vascular resistance increases. Blood flow to the non-vital organ decreases. Skin is a non-vital organ. As the blood flow to non-vital decreases, the skin temperature will also fall because blood is responsible for calorigenesis. In cardiogenic shock, obviously the heart is not able to pump, the cardiac output reduces. If cardiac output reduces, the systolic blood pressure will fall. If the systolic blood pressure falls, baroreceptors get activated, heart rate will increase. The circulating volume is less, hence the peripheral vascular resistance increases, so that more amount of blood goes to vital, less to non-vital, skin temperature reduces. Now, as the blood goes back into the right atria, the heart is not able to contract effectively. All four chambers are filled up with blood. So, all four chambers pressure will increase, causing increase in JVP and pulmonary capillary wedge pressure. In septic shock, there is loss of peripheral vascular resistance. Is a decrease in peripheral vascular resistance, more amount of blood goes to vitals, non-vitals when compared to vitals. So the blood flow to the non-vital increases, calorie density increases, hence skin temperature is going to increase. Now, if you look at this, the blood going into vitals and non-vitals have distributed, but the volume remains same. The blood coming back to the vascular pool is same. That is, the blood going into the right atria and the left atria will remain same. So JVP and pulmonary capillary wedge pressure remain same. Now, as it remains same, blood coming into the left ventricle is also same. Blood ejecting out, that is Stoke volume, remains same. Right? In septic shock, when I say cardiac output is equal to Stoke volume into heart rate, the Stoke volume remains same. But the aorta is dilated. So what will happen to the pressure? Obviously, if the volume remains same, the vessel will be dilated. So the net pressure in the vessel is going to drop. Systolic blood pressure will fall. Decrease in systolic blood pressure, baroreceptors, catecholamine, epinephrine, heart rate is going to increase. So here heart rate is going to increase. By this equation, Stoke volume remains same, heart rate increases. So net value of cardiac output is going to increase. That is what happens in the compensation of septic shock. The only thing that you remember in neurogenic shock, which is also a variant of spinal shock, which is a distributed shock, the baroreceptors is cut off. So here you will notice the heart rate and the systolic blood pressure, both of them are going to go down. That's your exam question. This we have already done, that is the color coding cannulas and all that. How do you monitor shock? By looking at shock index, which is heart rate upon systolic blood pressure. The better one is a modified shock index, which is the best method to monitor shock, because here you are using mean arterial pressure rather than only the systolic blood pressure. CVP is a central venous pressure. The normal CVP is 8 to 12 millimeters of mercury. MVOS is a mixed venous oxygen saturation, should be maintained above 65. Urine output is a best clinical method to monitor shock. How do you know the resuscitation is successful? For systemic circulation, we look for mixed venous oxygen saturation of more than 65. For muscle perfusion, I will use near infrared spectroscopy. For brain, near infrared. Gut is also near infrared, and the gut mucosal pH. Right? What is systemic inflammatory response syndrome? Where you look at the following component. Number one, you look at the body temperature, less than 36 or more than 38, WBC count of less than 4,000 or more than 12,000, respiratory rate of more than 20, heart rate of more than 90 beats per minute. If any two are positive, then we call it a systemic inflammatory response syndrome. What is sepsis? The definition of sepsis is systemic inflammatory response syndrome with known foci of infection. What is septic shock? It is sepsis with hypertension not responding to IV fluids. What is MODS? Multiple organ dysfunction syndrome, and more than equal to 2 organ fail at the same time. Now, the current assessment, we can go with 𝐶-SOFA scoring system, which is quick sequential organ failure assessment. The components of 𝐶-SOFA are systolic blood pressure, GCS, and respiratory rate. If systolic blood pressure less than 100, GCS starts to fall, and our respiratory rate of more than 22 cycles per minute. If any two are positive, it is associated. It is associated with poor outcome. It is associated with poor outcome. For surviving sepsis guideline, for the first 6 hours, the criteria to maintain a CVP of 8 to 12, mean arterial pressure of more than 65, urine output should be more than 0.5 ml per kg per hour, and mixed venous saturation of more than equal to 65%. Right? So this is all that you should manage in the context of shock and its management. Now, there's something called as, for abdominal traumas, FAST. We all know it. That's focus assessment sonography in trauma. You require 4P evaluation, that is your perihepatic space, pericardial, perisplenic, and pelvic. For E-FAST, that is extended FAST, you're using right and the left thorax, right upper abdomen, left upper abdomen, right lower abdomen, and the left lower abdomen. So all 4 quadrants of abdomen and 2 chests, so 6 sites of assessment. The minimum fluid required for the FAST to be positive, to be picked up, is going to be 100 cc. Now, how do you know there's a pneumothorax in your ultrasound? Number one, there's absence of seashore sign. There is absence of seashore sign. There's presence of barcode sign. There's presence of stratosphere sign. Presence of stratosphere sign. There's presence of stratosphere sign. Now, the most common organ to be injured in abdominal trauma is liver overall. But if I talk about blunt trauma specifically, the answer is spleen. For penetrating abdominal injuries, it is liver. Whereas the overall most common organ injured for a seat belt is a mesenteric tear. And the overall most common abdominal organ injury in a blast injury is going to be small intestine. Overall most common is going to be tympanic membrane. If they ask you most severe, is the one with the maximum air, the answer is lungs. It is going to be lungs. Now, grades of splenic injury are important. When you look at the grades of splenic injury, the grading is done on the basis of two criteria. One is hematoma, another one is laceration. If the hematoma occupying is less than 10% of the total surface area, depth of the laceration is less than 1 centimeter is grade 1. 10 to 50% of the hematoma with a depth of laceration of 1 to 3 centimeters is grade 2. More than 50% occupying the surface area and more than 3 centimeters depth, it is your grade 3. For grade 4, there has to be intraparenchymal hemorrhage involving more than 25% of spleen is devascularized, grade 4. Grade 5 is completely shattered spleen. For grade 1, grade 2, grade 3, which is stable, for all of them we go with conservative management, repeat CT after 24 hours, increase in grade, do an angioembolization. If it fails, do a splenography. For grade 3 patient, if it is unstable, directly take for splenography. For grade 4 and grade 5, if the patient is unstable, for all unstable patient, take the patient for emergency splenectomy. Take the patient for emergency splenectomy. Now, post-splenectomy vaccination is important in an emergency an elective. For elective, we do it 2 weeks before the surgery for pneumococcal, meningococcal, H influenza. For emergency, immediate post-op, we do pneumococcal. After 2 weeks, within 2 weeks period, we do meningococcal and H influenza. Pneumococcal, age less than 2 years, we give P7 valent. Age more than 2 years, we give PPV 23. That is the valency of vaccine that I'm going to give in this particular context. Okay? So this concludes your entire discussion on general surgery, right? So far, any questions, quick feedback? Quick feedback. All right, so if you have no questions, so I've split the entire marathons of surgery into 2 parts, that is part 1, part 2. So I've finished part 1 today. We'll pick up part 2 on Friday. Okay, there'll be another 2 hours and we'll finish it off. Okay, thank you so much for joining. We'll resume back in the next session of systemic surgery. So this was for general surgery. We have done 2 hours with a rapid revision context. Another 2 hours will be done for systemic surgery. We'll resume back that on Friday. Thank you so much. Take care.